Ora te marinon ki o papapaunau I te moana, hei ura I mā tātou I tēnei rā. Aroa atu, aroa mai, tātou I tātou, aunge hui e, tā ki e. Kei aku nui, kei aku roa, kei aku rangatira no hurinu o te ao, nau mai haere mai ki tēnei hui o tātou, o te rōpu mātai hauoro pāpuru o Aotearoa. Te hau kāinga Ngāti tō rangatira taranaki whānau, tēnā rā koutou, e mihi tēnei ki a rātou kua whetū rangiatia. Moi mai rā koutou, moi mai rā I tō moinga roa, ka maumahara tātou ki a rātou, mo ake tōnu atu. Our karakia this morning can be translated as let the calm be widespread, let the sea be like pounamu or glass, a pathway for us today. Be kind to each other and be respectful to each other. I then welcome our visitors here today to this second virtual conference of the PHONZ group, the Public Health Observatory of New Zealand group. I then acknowledged our the local iwi, and I paid our respects to those that have passed, and that's kind of what we do here in Aotearoa for public hearings and when we start off in a Māori environment or with karakia. Patrick has got some slides on housekeeping rules today, so can we have those up for a sec, please, Patrick?
You can, bear with me a moment. Okay, are those showing up?
Yep.
Good stuff. So we'll start off with just a very brief timetable for the day. We did indeed manage to start at 8:55. We've had a presenter pull out, so there's going to be an unscheduled tea break at, I think, 10:40, and then lunch break again at 12 o'clock through 12:40 p.m. And all going well, we should be wrapping up at around 2 o'clock. If you've got a question, please use either the Q&A button, which you'll find probably at the bottom of your screen. If for whatever reason that's not working for you, you can still use the normal chat, but we just prefer you to use the Q&A because it makes life easier for the host and the panelists to keep those separate. If you'd like to ask a question out loud with your voice, then please use the raise hand button, and that will notify me, the host, that someone's got a question, and I'll then unmute you and allow you to talk. The chat, we're just trying to leave for general comments and tech support if you need it. So attendees, you'll notice that your microphones and cameras have been disabled. You can't enable them, only I or the other hosts can, and we'll do that if we need to hear from you. A few quick notes for presenters as well. In the way of timekeeping, we're going to ring a bell, which will sound like this. 13 minutes into your presentation. So that should warn you that you've got a couple of minutes left to wrap up the actual presentation part of your session, to leave, give or take 5 minutes for Q&A. We are recording this, of course. No one's told me that they don't want to be recorded. So that's good. And if you've got a video as part of your presentation, then when you start sharing, you'll need to make sure that you've ticked the little share sound box that you get in the sharing menu, or you need to enable that after the fact. Otherwise, we'll just see a video and get no sound. And if you need any tech support during this meeting, flick me an email. You should have all got my emails by now, or use the chat to get in touch with me. And if you've got any questions, sing out. Otherwise, we will carry on with the day.
Thank you, Patrick. I'm Peter Himura. I'm going to be introducing all the speakers today, and Patrick and other PHONZ steering group members will help me at question and answer time to make sure that we all have a chance to participate into the hui. Thank you all for turning up once again. It's almost time for our first speaker. Tēnā koe, David. No mai haere mai ki tēnei hui o tātou. Welcome, David. You're our first speaker today. David is an independent consultant coming to us from Liverpool this morning. was it afternoon there today, and he's talking to us about the health system transformation lessons from England. Tēnā koe, David, nau mai, haere mai. Over to you, David.
Thank you, Peter, and good morning to everyone over there. Kia ora katoa. Just by way of introduction about myself, I was a Director of Public Health in an area of Southern England for 15 years, both within the NHS and local authority settings. But for the last couple of years, I have been working with Public Health England on COVID until late last year. I have now merging into retirement and spending more time fixing houses than I'm doing anything that might be meaningfully called employment. I should perhaps flag, I did lead the Population Environmental Health Programme at DSR for a few years from 2001, so I do have some familiarity with some of the people, and Barry Borman doesn't look a day older than when last time I saw him 20 years ago. It's good to see you. Please take that. Okay, so I've just got 5 slides. What I'm going to do initially is basically describe the principal organisational changes that have taken place over the last 10 years in England. I do highlight it is England. We're not going to talk about Wales, Scotland or Northern Ireland, so we'll have significantly different systems. And then I'm just going to talk about some key issues under 3 headings, basically organisations, data and intelligence, and workforce. I should highlight that my perspective is very much that of an end user of public health intelligence at a local and regional level. And many of the issues that I'm going to be raising all very much remain works in progress. But I do hope it will provide some food for thought for you in NZ and on your journey that you're on at the moment. One final point, I'm being followed by an expert in the field, Chris Skelly. So if you've got any difficult questions, could you please hold them for Chris rather than ask me, because he knows most of everything I know about intelligence I learned from Skelly. So just if I can now, just to share my screen. I've only got 5 slides, so it hopefully shouldn't be too painful. Great, okay. Hope everyone can see that. Okay, we'll go back, if we may, to 2012 very briefly, where public health staff, and I do exclude environmental health officers from this, sat primarily in either the Department of Health or the NHS. In 2013 saw the formation of Public Health England, which existed until October of last year. This was a merger of 70 organisations, forming 3 national centres and 10 regions. All the national and regional public health staff in the NHS and the Department of Health, including the Health Protection Agency, all went to Public Health England. Local public health staff, i.e. those not in national or regional centres, moved to what are termed top-tier local authorities. That's a peculiarly English expression, which means it's generally refers to either unitary or county council authorities, but excludes district councils. This resulted in the formation of 134 directors of public health, covering populations ranging from 34,000 to 1.4 million, with budgets from 39 to approximately 209 pounds a head at that time. The Public Health England lasted until October last year, which saw the formation of the United Kingdom Security and Health Agency, particularly difficult acronym to get your head round, abbreviation rather, and all the national and regional staff were then split from Public Health England, with the health protection functionality and staff going to what's it called UKSHA, United Kingdom Security and Health Agency, the health promotion staff going to the Department of Health, and healthcare public health staff going to the NHS. The local staff remained as they were, so the status quo remained in local authorities. If you can make sense of that, you're a far better person than many around, but I thought I'd just flag what happened. They were obviously, as you're as is likely the case, or often the case with these changes, they were all done in a fearsome rush and saw these things go through in very rapid time. Let's go on to the next slide. I'm just, if I may, just talk about organisations over the next couple of minutes. I've titled the first one heading, Public Health is Coming Home and Changing Horses. The gentleman on the right there in the picture is the first president of the Association of Directors of Public Health. And the reason he's up there is that the rhetoric of public health is coming home was quite a persuasive rhetoric during 2012. And the suggestion was that local public health staff went back to local authorities, where the image of an independent medical officer of health with a very independent voice speaking on behalf of the people was still a very potent image. The reality, though, sadly, was that in 2013, I'll preface that by saying medical officers of health in England last sat in local authorities in 1974. And over the intervening 30 plus years, the local government landscape had changed very significantly, not least of which was significant reductions in funding to local government from central government. So the rather rosy spectacles that people entered local government with was soon soon fell by the wayside, and it was quite an interesting experience. The end result was that some directors of public health ended up sitting in county councils, some in unitary authorities, and some in district councils. So there were very different arrangements taking place, which took a long time in many instances to sort out. I put changing horses in one of the things that we didn't think about, and I don't know if this has any resonance with the New Zealand situation, was that we thought that leaving the NHS and transferring to local authorities would be a painless separation. Unfortunately, like most separations of partners, the NHS wasn't very happy about it, and re-establishing relationships took a long time in many instances, and there was quite a sense of grief, of loss at losing public health teams from out of the NHS. Now that may well not apply to your situation, but it certainly was a feature of the story here in England over the last 10 plus years. My second comment there is about you can bring a horse to water. I think this may be slightly more relevant. The 70 organisations that were shoehorned into PHE survived for approximately 8 years together. I think it's fair to say over that 8 years, it was inadequate progress was made in actually bringing the different teams and the different cultures together, such that one of the many comment that one of the reasons for separating them again when the formation of the United Kingdom Security and Health Agency was actually a recognition that putting all the different elements together within one agency hadn't worked. I think those people who are on the inside there would comment that cultural barriers to working together were really not adequately addressed at the outset there. And that's something that I think probably is a message that would resonate with all change processes, but they were very significant, very deep-seated, and very enduring in parts of Public Health England and different agencies. That was just a little bit on the organisational challenges. We'll now go on to a little bit about data and knowledge. Just 3 headings here, something that we'll all be very familiar with, the joining up of data and joining up of thinking. I mean, this invariably throws up questions around IG, metadata, quality, etc. I think that my experience and that of others was that it was often assumed that someone else was sorting out issues of IG, etc. Someone mystical person in the centre in the ministry or Department of Health was going to sort it out. However, as the years went by, it rapidly became apparent that no one was sorting it out. In fact, matters were getting worse with the introduction of new data, laws and regulations, and the progress was slow, very slow. The other significant assumption was that we all knew what everybody else was collecting and why they were collecting it and what they did with it. And in fact, nothing was further from the truth. So I think those people that did make progress, in fact, went back to the very beginnings and actually just started to explore across organizations who was collecting what, where it went, and how. And I think there was a tacit assumption that's all through this, that somebody knew what was going on in terms of data sharing and how it was all going to be joined up. And I think it's still a very open question, certainly in the new organizations. I put in what question are we trying to answer? Certainly when public health in the local NHS, we were so busy reporting historical data, I think we often forgot the question we were trying to answer and the audience we were trying to respond to. And I think there is and remains a very real question about, a very real challenge about being clear on the question, finding the right data of the right quality from the right people and developing a compelling narrative. I think we've omitted a lot of those elements, and we also failed to ask a rather simple question often about who can and will take action on it. And I think there was this assumption that once people were shown the data, it would be self-evident what they had to do. This has become more recently quite acute with the advent in England of integrated care systems. And I appreciate in NZ you've had those up and running for quite some time. But we're finding here that as clinicians in particular in the health services are starting to own population health outcomes, providing them with this phrase, and I'm not sure I like it, but Skelly will insist I use it, actionable intelligence, is really becoming quite a challenge. So just sitting back and routinely collecting, collating, and doing little bits and pieces of data is no longer an option. Just the third issue around data and intelligence is this chronic issue of wicked problems. I've put the foresight map of obesity systems in there, and that's just one of many examples. There are perhaps too many contemporary issues which might usefully be defined as wicked problems, and they do genuinely require very different mindsets, very different skills and tools. When they do happen, and I will only briefly mention ESR and its work on Karakia with Jeff Powell and Chris and Ginny Baker as an example of when they do it right, it can be spectacular. One more slide, program and functions. I'll just workforce here very quickly. Both three organizations use domains and programs as the principal units of change and often admitted consideration of core public health functions and tasks, in particular intelligence. The result was significant omission and duplication of intelligence and other core functions. And I think my suggestion would be it's important to keep core function as the building blocks for change. Because if you separate them, the challenge of joining the dots up in times of need, for example, COVID, has proven very difficult in England. Similarly, public health intelligence, while integral to all programs, was rarely specifically budgeted for and was squeezed when budget pressures fell. Training in particular was very vulnerable to budget pressures. And I think if we were to do it again, ensuring budgets, local, explicitly include intelligence and training costs, I think would have been, in retrospect, a good idea. Equally, many local authorities were too small to justify a critical mass of intelligence staff. And those local authorities who were big enough to do it really added value, and in particular added value in working with other agencies like fire and police and produced some really significant work there. I'll finish up then, if I may, with one last slide. This is an illustration for which I have to thank Michael Baker, who in ESR days helpfully used this as the one on the left-hand side for a metaphor for the public health system, the three domains of public health combining together to deliver services and outcomes. it's always a really helpful figure. I'd like to suggest in the context of this discussion, we could perhaps have a complementary view in the second picture there of a system as a solid base of intelligence underpinning all public health actions and outcomes. And I think that's just a model that could prove to be something for discussion during this time. So I think I've got in under the 15 minutes just. Thank you for your time.
Tēnā koe, David, ngā mihi ki a koe. Thank you, David, for this very enlightening presentation. I was particularly interested in the restructure and transfer to local areas and the re-establish of relationships. And I'm sure, as you know, we're going through our transformation as well. So I think that we're having the same type of challenges. And perhaps I'll start off with the first question. How do you think the re-establishment of relationships, how do you think that's working?
I think there's a long way to go, Peter. I think it's fair to say that prior to the formation or the reorganization last year, there was definite signs that relationships were improving. I think the formation of integrated care systems is showing promise in terms of integrating public health in the wider sense through a population and place lens back into organizations. But it took several years, to be honest, before real progress was made.
We've got a question coming in from Tom, who should be able to speak now. In that case, we'll move on to Vladimir, who also has a question.
Good morning, all. To the presenter, so my question is, you mentioned that there are a lot of worries about duplication of functions. I have, say, different direction of worries. I'm working in local, but I'm very keen to contributing to, say, quite general things. So what do you think? The over-centralization or duplication, what is the more dangerous of the trends? Just to compare, if we move everything that high-level analytics into center, or we duplicate that by running similar projects, say, in several places. Thank you.
I think that's a very moot point, Vladimir, very moot point. I think my comment would be that I think it's really important to be clear what the expectations both of the centre and the periphery is. So what tasks are you being expected to do at the periphery? And then I think you can meaningfully define what sort of skills and workforce you need there. I think what would happen in England was that a lot of the intelligent tasks were buried in the differing services. A lot of the skills were spread over differing programs. There wasn't a real sense of what we needed in the round to perform that core function of public health intelligence for the population and the place we were serving. So I think it's very moot. I don't know there's an easy answer to it, but I think getting clarity about what the services provided from the centre to the periphery are and what the periphery might reasonably be expected to do, and therefore what resources they might need to do that.
Thank you. Just in order of discussion, it's because I'm very much say interested in that outcome of these things. My suggestion would be if we not provide the tasks covering 90%, for example, of workforce resources, but say leaving about say 20 or 25% of time for people to work on their say own projects, just to leave some space for local initiatives, say, and by supporting them, for example, in the order of research grants or something similar. So that would be my suggestion.
I think that's very sensible, Vladimir. One thing I meant to mention at the end there, one thing was building relationships with other agencies locally, and it's something that we struggled with after the first reorganization. But one set of agencies which we didn't optimize the relationship with, and given we're sitting in Massey, was universities. And whilst in the big and urban areas, there was obviously a relatively easy and long-established relationships between public health units and universities. In rural areas, that was not the case. And I think it was, once they did become established in certain areas, they were very mutually beneficial. And I think I'd wished we'd done that earlier and in a more structured and systematic way in retrospect.
New Zealand, thank you. New Zealand is a different country, and a rural area, for example, Northland, is just the same time for me to drive to Auckland as some Aucklanders spent to reach the Central University. So that's just, let's take into account the specificity of New Zealand. Thank you very much for your.
Thank you all for your comments. It's time to move on. Our next speaker is ready. Tēnā koe Chris, no mai haere mai. Chris comes to us from Bath in the UK. He works for the Department of Health and Social Care, and he's talking to us about rethinking public health intelligence. Tēnā koe Chris, over to you.
Thank you very much, Patrick. I will share my screen. There, Patrick, can you see the right screen?
Yeah, we've got you.
Excellent, thank you for that. Colleagues, thank you. This is really an entertaining opportunity. You don't get to speak to your colleagues in public health intelligence that often. And this is an opportunity to talk to you for 15 minutes, well, maybe about 14 and a half minutes now. And so that we can think about public health intelligence, and indeed, I think to a degree, think about public health full stop. The lead-in from David regarding complexity and wicked problems is a real gift here, because I don't have to talk to you about complexity to start right up, but I will give you a bit of a framing of that, if you will, to help us rethink perhaps some of what we do both in public health and in public intelligence. Let's just do the next one here. Great, okay. I'm coming to you from the bottom of my garden in a shed in England in the middle of the night, and we're having a conversation, or hopefully we'll have a conversation. Please use the Q&A to put some of your thoughts as we go along, and then we can pick that up in discussion either here or at a later point. I'm giving you here two social icons, if you will. On the left, we've got a quote from an American journalist, satirist from the early 20th century, a fellow named Mehta. For every complex problem, there is an answer that is clear, simple, and wrong. And of course, he was talking about politicians, and he was talking about grasping at something that people can understand, but doesn't necessarily reach to the heart of the problem. And this quote was from 1917, so well into the First World War, and the beginning of disillusionment, if you will, with the level of complexity in society. The social icon on the right is a album cover, 1969, in the Court of the Crimson King, of which the first and most widely known song was 21st Century Schizoid Man, a song about the Vietnam War. So we're in another era of warfare, and this time you can tell by the art that it's not a witty or a dry comment about our inability to cope with this complexity. Now we're getting quite anxious about that. And I think our modern world is messy is probably the understatement of the day, particularly if you work in public health. But let's go and let's examine this beginning of wicked problems, if you will. So what we do, I've simplified what we do to 4 elements in a loop. Okay, it doesn't get any better than this. I call this the request-based intelligence. This is what we mostly practice, and it has a loop where we engage in a request from a client. But before that, we try to do some sense making, and then I've put all the highly technical stuff into one box called develop. We develop the intelligence, then we'll engage to see if we've got it right, and we'll try and refine our understanding with the client to some extent. This is fairly common. You could draw arrows absolutely everywhere, but let's just keep in our mind that this is the base of what we mostly do. But there's another way to view intelligence, and sometimes we get lucky enough to look at this. I'll call this problem-based intelligence. Same kind of engagement, same kind of refining the process of understanding, but we're reaching beyond the request, and we're asking, what problem are the clients trying to solve? And that's what we're helping them with. So it's earlier in the thought processes. Additionally, we could, in fact, go and look at the impact that our intelligence has, and sometimes we're lucky enough to be able to do that, and try and evaluate whether or not we made a difference with that intelligence. It's quite a challenging and very time-consuming thing to do, and we don't tend to get enough time to do that. I would say, however, that regardless of whether you're engaging on the problem or the request, if you're not engaging a client, you're probably not doing intelligence. You're probably doing some form of health information, okay? So I think engagement's essential to define what it is that we do. But I think the more interesting engagement comes when we look at the problem itself. Now, if we put that to the side for a second, and we ask ourselves why we might be having problems engaging at the problem level, got this little sort of another loop, and this comes from a fellow named Russell Acoff, and he says, well, basically you're starting with this. The first thing we want to do after we get a request or we try to look at a problem is we break it apart. It's called analysis thinking. And then once we break it apart, we try to understand each of those parts. And then once we've understood the parts, we aggregate it all back up together for an understanding of the whole. So somebody comes to you and says, we're going to do something in the area of diabetes. I need you guys to start building a picture of that for us in whatever area. First thing we do is we break it down by age, we break it down by gender. We might look at it in terms of the risk factors. We might even go to wider determinants. So we build all the parts of what might be related to diabetes, and then we aggregate it into a report or some description. And that's how we answer people. But this is a pretty limiting thing. And Russell Acoff has this wonderful example, and I'll try to remember how he says it. Basically, what if a bunch of aliens came to Earth and they captured a car, and they took this car up to the spaceship and they wanted to understand it, so they take it apart, right? They got the engine on the floor, they got the wheels off, maybe they're even pulling the pistons out and really going to town, so they know how each bit of that car works. The head alien comes down from whatever planet they're from, and he says, okay, guys, why are there 5 seats in the car? And you got all these green guys sitting there looking at each other going, I don't know. And it's completely understandable. There is no way that you can tell why there should be 5 seats in an automobile by taking it apart. And this applies to everything we do, okay? Because it's related to the purpose of the car, and you can't tell the purpose of a system by taking it apart. So there's another type of thinking, something that Russell Acoff articulated, as did other people, about this about the time of the Second World War, just after that, in this window where I showed you the social icons. What if you get a problem or request, and instead of breaking it apart, you say, okay, what's this a part of? So we're going the opposite way now. And once you've asked that question, what's it a part of? Then you can say, okay, so what's its behavior? What's happening with diabetes within the hospital system, if that's what we assume that it's a part of? And then we can take that understanding of what's going on in that next level of system up, and we can disaggregate that to explain how the parts are related to the whole. So it's completely the opposite of systems thinking. Now, you pull these things together and you get systems thinking, okay? Or so it's analysis thinking, synthetic thinking, get you systems thinking. Now, you don't have to just go in a loop at the top or a loop at the bottom. You could do a figure 8 and go back and forth. But what's really important is that you start with synthetic thinking if you've got a problem to help try and understand. Because you can't understand how things work if you first break it apart. You don't understand what the purpose of the system is. You don't understand the goals or aim of the system that you're working with. I want to give you 2 examples. And I've got one slide after this. So we're getting close to the end. This is a systems thinking project I worked on with a bunch of people in the urgent and emergency care field. And they were very interested in waiting times. So the demand was going up in the emergency departments and associated facilities. Waiting times increased, quality of care decreased. So they ended up getting more funding to increase the size of the A&E. Does that sound familiar to you guys? Because it didn't do a damn thing about demand, did it? No, it just put off the capacity, allowed them to pretend demand didn't exist for a period of time. So they wanted to look at what caused demand. So they looked at disease management. The big problem in emergency and urgent care is chronic diseases. So what if we manage disease more effectively? How would that work? And that works out pretty good, except when health and well-being of the population is going down. And then you get a vicious circle. As that decreases, then the effectiveness of disease management gets overwhelmed. So that decreases, making more demand. So they said, okay, so primary care and disease management is not the solution here. What is? Started looking at disease prevention. Now, I'm just facilitating this. These are the doctors working in the emergency room. And we talked about socioeconomic inequality. We talked about lifestyle and living conditions, the accumulation of risk factors over a lifetime, their impact on health and well-being. Every single one of those doctors agreed that disease prevention is what they needed to focus on to solve the problem in the A&E. Okay, even superhuman efforts by a team of 5 million eventually will fail because it's being driven by something that's outside the health system. And so that was a wonderful way to get into, so what do you want to monitor, guys? Is it still waiting times down here? Or do you really want to measure the accumulation of risk factors in society? The second project is an exemplar of using systems dynamics as a modeling tool, which is really accessible now to analysts, where we can break a problem up into a number of boxes. And of course, if you had a SEER model during the COVID epidemic, you kind of recognize this pattern. This is a generic one I built to help public health colleagues understand how interventions work, how all public health interventions work. Reach, compliance, efficacy. You multiply those 3 numbers together, that determines the success. But you could simulate that, and what a simulation might look like would be some behavior of that intervention system over time, giving you how many people successfully completed that. Now, you can add to the complexities, you can look at the finance side of things, you can look at the population demography. All those things together are very complicated. In fact, you might even call them complex. Put them in a dynamic systems model where you've identified those individual boxes by analysis thinking. That's the structure of the model. And then run it over time and start to tease out the behavior of this system of intervention on each of those components. So what is the demographics impact on that intervention? What's the compliance aspect? What's the reach? How do all these things impact and interact with each other? And you can begin to tease these things out. Thank you. So last slide. to mirror the beginning social icons, I'll end with a Russell Aikoff quote, which is quite apropos. He said that managers don't solve, or maybe he even said managers don't solve any more problems, they manage messes. And of course, what they're really talking about here is a mess is something that we have a lack of understanding about. It's a situation where there's no clear agreement about exactly what the problem is, right? So they didn't understand the problem. They just got this request somebody's made somewhere down the track. And it's also rife with uncertainty and ambiguity. I think David had a sign up there, the Buddha problem. So people aren't really certain of which way to go because they don't have a good understanding of how the system as a whole works. They only get a picture of the parts, and you can't understand the whole from the parts, right? Remember the aliens coming down with the car thing. So I think I'll leave it there, except I think that this is a time after COVID to rethink how intelligence and indeed public health is going to move forward to try to solve the real problems in the world and actually generate a bit of action. Thank you very much.
Kia ora, Chris. Ngā mihi mō tēnā. Thank you, Chris, for that very enlightening talk. I really enjoyed your use of idioms, aliens, horse to water, and, well, I put managers don't solve problems, they manage messes. I put that in that box too. And the other part of your talk that I really like is your, well, these kind of three comments about teasing out what the problem is, looking at all parts of diabetes and trying to solve the actual problem of the client. So I really enjoyed those aspects of your talk. So thank you very much for this talk. Are there any questions? No, I don't see any.
Stunned to silence in the morning.
Oh, well, Chris, maybe you can take a few minutes. I suppose you're off to sleep now. So, thank you very much.
I'll stay till lunchtime.
Oh, okay.
You're welcome.
Valdemar, sorry for talking over you.
Just
trying to talk over you a bit before. We are running to a schedule, so we've advertised start times at certain times. So where possible, I'd like to give the next speaker the chance to start on time, and it's probably more important for those people that are coming in for a Pacific talk. So sorry, I did try and talk over somebody to cut them off last time. So this is the first time I've done this online, so you'll have to forgive me. And I think everybody's made a mistake once or twice in their life, so there's nothing too much to worry about.
We do actually have one question and time for that one question since we're running to time. Vladimir, go ahead.
thank you. I do have a lot of questions. But
gone quiet, Vladimir.
sorry, I have some technical problems later.
Okay.
Okay, it's almost time for our next speaker now. Tēnā koe Melissa, no mai haere mai ki Wainganui o tātou. Our next speaker is Dr. Melissa McLeod, and I know Kirk's very much looking forward to hearing what you say, and so am I. This is a hot topic for us here in my department of the ministry. Welcome, Dr. Melissa McLeod. She's from Otago University, and she's talking to us about we still don't count the undercounting and underrepresentation of Māori in the health and disability sector. Thank you, Melissa, over to you.
I'm just going to screen share. And can I just check that you can see my slides? Anyone? Great. Tēnā koutou katoa. I'm Mel McLeod, and actually sitting next to me, if you lean in, is my colleague, Associate Professor Ricky Harris, and we did this particular piece of work together. So Ricky's here to either take over from me if I end up in a COVID coughing fit, but also to assist me with any questions at the end, particularly the more difficult ones. As Peter has mentioned, our presentation is about the undercounting and underrepresentation of Māori in health and disability data. So why does ethnicity data matter? Well, I think these two quotes quite nicely summarise the importance of ethnicity data. Being counted is an acknowledgement of both existence and value. It means that one matters. It is the hallmark of treaty promise. History will judge our commitment to the treaty in part by our ability to ensure that people are counted, that disparities are acknowledged and appropriate policies are put in place, especially those which eliminate disparities between Māori and non-Māori, a solemn commitment by the Treaty of Waitangi. So ethnicity data protocols have now existed for nearly 20 years. So why are we still talking about ethnicity data quality? Well, the short answer is because we haven't actually solved the problem. There's continuing evidence of the systematic undercounting of Māori in health data sets. This includes our National Health Index and other health data sets. In the context of our research on modelling screening interventions, we're really aware of the importance of ethnicity data quality at two distinct levels. At the aggregate or population level, ethnicity data quality impacts on our ability to estimate health incidence or prevalence, rates of disease, measuring inequities, and also our progress or not over time in achieving equity. It also has quite important implications for the funding of health services. But in addition, ethnicity data quality is also really important at the individual level, where an individual's ethnicity may determine things like their age of eligibility for cardiovascular risk assessment or diabetes screening. It might impact on sore throat management. It impacts on eligibility for some diabetes treatments. And it's also important in the context of the recently announced age extension to the bowel cancer screening program. So this particular piece of work that we completed aimed to examine ethnicity data quality, in particular the representation and potential undercounting of Māori in health and disability data and the implications of this for measuring inequities. Our research team is guided by kaupapa Māori research methods, particularly kaupapa Māori epidemiology. And so that includes our right to monitor the Crown, the right to be counted, the right to have a powerful voice, and the right to name racism and colonialism as fundamental causes of inequities for Māori. Our kaupapa Māori epidemiological approach supports the use of a Māori non-Māori analysis as a reflection of the treaty. So our study design, we undertook a descriptive study that compared the recording of Māori and non-Māori ethnicity across a range of data sets in two main ways. And these two main ways reflect those two different levels at which we think ethnicity data is important. The first was a population aggregate analysis, where we compared the total numbers and proportions of Māori and non-Māori overall and by age and gender for 4 2018 data sets. And those 4 data sets were the estimated resident population, the census usually resident population, the health service user population, and the primary health organisation enrolments data set. We did a second analysis, which was an individual linked analysis, and we did this to directly compare NHI ethnicity to a Census 2018 self-identified standard. In both of these levels of analyses, Māori were identified as anyone who had their ethnicity recorded as Māori either alone or in combination with any other ethnic groups. Non-Māori were all other people in the data set, and this includes those with missing ethnicity data. And so I'm just going to present you the results of the aggregate analysis first. So within this table, you can see of the 4 data sets that we examined, the estimated resident population has the most people at 4.9 million, as well as the highest proportion of Māori, so 16.7% of this population were identified as Māori. In comparison, the health service user population was the closest in total size to the estimated resident population, but had a lower proportion of Māori at 15.5%. And the PHO population was the smallest in size and also had the smallest proportion of Māori. It's important to note that within the health data sets of health service user and PHO, at this level of data, we can't tease out the relative contributions of differential access to care and therefore the ability to be represented within the data set from potential misclassification of ethnicity or undercounting of Māori within the data set. We are, however, able to examine those sorts of factors more closely in our individual linked analysis that's coming up shortly. So this graph shows the percentage difference between the estimated resident population, which is the horizontal black line, and the other health data or the other data sets for Māori and non-Māori males. And so what you can see is that all of the solid coloured lines sit below the estimated resident population line. And so this means that compared to the estimated resident population, there are fewer Māori males in every age group in the census, which is represented by the solid grey line, the health service user population, which is the solid yellow line, and the PHO population, which is the solid blue line. And it's also important to note that the percentage differences from the estimated resident population are disproportionately larger for Māori than they are for non-Māori. Non-Māori are represented by the dashed lines of the same colour. While I think there's general acknowledgement that young males tend to be underrepresented in our health data sets like primary health organisation and health service user, and we can certainly see this as the dip in the lines in the sort of age 20 to 30-year-old age group. What we were quite surprised to see is that this underrepresentation actually continues for Māori males across all subsequent age groups. And so if you have a look at the solid yellow and the solid blue lines, we don't actually pick up again after the age of 20. Also looking at this graph, in particular, the positioning of that solid yellow line, it's really interesting just to reflect on the use of the health service user population for Māori COVID vaccine coverage and what 90% coverage or the 90% target coverage for Māori might actually mean. This is the same graph, but this time for females. And similarly, we can see that Māori females are underrepresented across all of the data sets compared to estimated resident population. So this means all of those solid lines, the grey, the yellow and the blue, sit below that horizontal black line. In contrast, we can also see that non-Māori females are actually overrepresented within the health service user population compared to the estimated resident population, and this occurs for multiple age groups. So we're now going to move on to the results of the individual analysis, individual linkage. So in order to examine the misclassification of ethnicity and the potential systematic undercounting of Māori on NHI data, we undertook a linked analysis. To be eligible for inclusion within this analysis, people had to be enrolled in a PHO as at the 1st of April 2018. They needed to have self-completed the ethnicity question in the 2018 census, and we needed to be able to link them to the IDI spine and to the Ministry of Health NHI data. So we were able to link 78% of people on the PHO dataset, but we do note that linkage varied by ethnic grouping. We were able to get 64% of linkage for Māori and 80% linkage for non-Māori. And that's really important to keep in mind when you're interpreting the results of this analysis and think about who was not captured within the analysis and whether their representation might be better or worse. Within the PHO linked sample, if we used census ethnicity data, we got about 492,000 of the population identified as Māori, which is 14.1%. In contrast, if we used NHI data to identify Māori, we only got 415,000 individuals, which is 11.9%. Now, it doesn't sound like a massive difference, sort of 12 versus 14%, but in actual numbers, this is a difference of 75,000 individuals within this data set. And that's a number that I think is probably of some material importance, particularly in the context of funding and primary care funding. And if we were to be looking at a funding formula that captured ethnicity, the source of that ethnicity is probably quite important. It's also interesting to note that both of these proportions are lower than the total population percentage of Māori that we see in the estimated resident population. So it may be that both the 14.1 and 11.9 are underestimates of the Māori population. This graph gives us an idea of how well NHI ethnicity data performs if we were to use it to invite Māori to targeted healthcare interventions like cardiovascular risk assessments or the bowel screening age extension. What this graph assumes is that the truth is ethnicity as identified within the census. And we think that's a reasonable assumption, given that the health and disability system ethnicity data protocols are based upon the census question. This graph tells us what proportion of those identifying as Māori on the census can be found through NHI. So what we can see is of the almost 492,000 individuals who identified as Māori on the census, we can find 387,000 of those, or 78.7%, were also recorded as Māori on NHI. Putting this another way, it means that 21%, or about 1 in 5 Māori on the census, were not identified as Māori on NHI. You can also see, if we look across the bars, that there's some variation in the level of match between the census and NHI by age, with the youngest age group, those aged 0 to 4 years, having the highest level of match at about 90%, and a much lower level of match in those aged 20 to 24 years, where up to 30% of Māori are missed on NHI. What you can also see from this graph, when we look at the relative heights of the orange bars versus the blue bars, is that the level of match that we see is actually lower for Māori males than Māori females. And this is more apparent in adults aged over 20 years, where the matching for Māori males remains consistently low. So what does this mean in the context of the bowel screening age extension? The current bowel screening age range is 60 to 74 years, and after years of advocacy from Māori and others, the Associate Minister of Health recently announced an extension for Māori and Pacific to be screened from age 50. So based upon the analysis that we did, if we were to use NHI ethnicity data to identify Māori aged 50 to 59, 1 in 5 eligible Māori individuals would not be invited to the program. If we applied this level of undercount to the numbers of Māori sitting within the estimated resident population, what that would actually mean is that we would miss up to 18,000 eligible Māori individuals. But wait, there's more. If we were to use NHI ethnicity to identify Māori individuals aged 50 to 59 years, we would actually invite up to 4,200 individuals who were not eligible for the screening age extension, but were invited because they were misclassified as Māori on NHI. I just want to note that these numbers are estimates, because what these numbers don't account for is that some Māori will be invited because they also identify as Pacific, or will be invited because they have been misclassified as Pacific. Just a really quick mention of net undercount. When we measure ethnicity data quality, we can do it in a range of different ways, and net undercount is a measure that you will see relatively commonly. Net undercount differs from the data that I've presented in the previous slide, because it both accounts for those 18,000 Māori who were missed from the NHI, but it subtracts off the non-Māori, or the 4,200 non-Māori who were invited to bowel screening by virtue of being misclassified as Māori. So it's sort of a balance of the pluses and minuses. And so just for those that are interested in the net undercount from our research, the net undercount for Māori and NHI was measured at 15.7% overall. So in terms of concluding comments, the misclassification of ethnicity data impacts at the aggregate level on things like the rates we can measure and the inequities that we measure. But also it's really important to have accurate ethnicity data to be able to identify Māori for targeted healthcare. And I think we're increasing our reach in that particular area. There are quite a range of methods that have been and are still being developed to try and patch the holes that we have within our ethnicity data collections. These are approaches like using Ever Māori, applying adjusters, or using algorithms. However, we believe that we actually need to address the underlying problem and just collect better data. And we can do this by applying the processes that are outlined in the ethnicity data protocols. I really encourage you all not to fall for the myth that NHI ethnicity data is good now. Instead, I encourage you to use ethnicity data critically and reflect on the impact of this misclassification on your findings. Also, as a final sort of comment, while I acknowledge that numerator denominator bias is really important, it's actually not the only ethnicity data problem that we need to solve. Māori representation in our data sets, or underrepresentation in our data sets, and misclassification of ethnicity matter too. And finally, I would just like to acknowledge the wider team, and I think a number of these team members are on the call today, so I might flick to you to answer the hard questions, and also acknowledge our funding from the Health Research Council and the data access from Stats New Zealand and the Ministry of Health. Kia ora koutou.
Tēnā koe, Melissa, ngā mihi ki a koe, ka tahi te kōrero te whakahihi. Thank you very much for this enlightening and stimulating topic presentation, Melissa. I work in the Māori Health Insights team, and we're very interested in this. It is quite concerning, 75,000 individuals missing, 1 in 5 not invited for screening, as you think. I have, is there one question, is there a question in the?
More of a comment than a question. I'll pass it on. Richard says, fantastic presentation, Mel. Thank you very much. A long way to go. Keep shining the spotlight. Okay, I have one question, Melissa, about the underrepresentation in the NHI. In the when loading it, recording ethnicity in the health sector is what's the word? It's self-reported. how much do you think, or what proportion of those 75,000 you think may actually purposely decide not to register as Māori or lodge their ethnicity as Māori in the NHI? You think it's a purpose decision, or you do not read too much into that?
I tend to try and avoid the sort of victim blaming narrative of sort of blaming Māori for not identifying themselves within our health data sets. I think probably the biggest factor for the underrepresentation of Māori is that we're not actually complying with ethnicity data protocols, that we're not offering the opportunity to truly be self-identified, that in many settings we're still using the wrong question to assess ethnicity data. So I like to focus more on our compliance with ethnicity data protocols. Yes, Māori individuals have the right to choose to not identify, but I haven't actually seen any evidence that that is an important factor in the underrepresentation of Māori. Ricky, do you have anything to add to that? That was a shake of the head. Ricky didn't have anything to add.
Kia ora, Ricky.
Chris, I think you're first with your hand up for a question.
Excellent. You've got to be quick. That was an excellent presentation. I haven't worked in the New Zealand health system since 2005. It's interesting to see which problems have been solved and which problems haven't been solved in a long period of time. changing the origin of data and the collection of data seems to be glacial. It doesn't matter which country you're in. In the meantime, between getting the right data, are there any clever statistical methods that you can think of, like capture, recapture methods that would give us better estimates almost immediately, which would then keep the pressure on data change processing?
I think that there's actually quite a lot of work in the area of trying to patch up our data sets to try and have it better represent what we think is the truth. The problem with that is that when you patch the data, you're actually doing it at the aggregate level. So you're getting closer to things like the population proportion, but it doesn't address the other issue we have, that we need to use the data to accurately identify individuals who are Māori for healthcare services. So while I think the patching of the data is sort of a necessary short-term solution, what we actually need to do is get accurate data so that we can use it at both the aggregate and at the individual level.
I have something to add.
Oh, Ricky's got something to add this time. Here she is.
Oh, kia ora. And just on that vein, I think that the like clever statistical methods that you're talking about, I just want to say that they're actually quite time consuming and require a lot of skill and resource. And it means that the data is still not only accessible to like a few people or a small proportion of people. It means that it's not, you know, doing a standard rate or for your organisation for people who might not necessarily have a fancy biostatistician on board is like less accessible. So I think there's inequities in that as well.
Tēnā koe, tēnā kōrua Melissa, ko Ricky, ngā mihi anō. Thanks again for such a stimulating presentation, Melissa. Our next speaker is here. Tēnā koe Pō, no mai haere mai. Welcome, Paul, to this conference. Paul is from the Health and Safety Commission, and he's talking to us today about exploring the consequences of lockdown with data. Tēnā koe, Paul, over to you.
Actually, sorry to cut in. We did still have a couple of questions left unanswered on that last one. We do have our unscheduled morning tea break to cut into. So if you didn't get a chance to get your question answered for either Melissa's presentation or for Chris's before that, we'll open up the floor for questions and further comments during that tea break. So don't worry if we've missed you out, we will get around to you.
Okay, Akamarie koutou. Just share my screen, so you can hopefully all see. Yeah, kia ora. So my name is Paul McBride. I'm a senior analyst at the Health Quality and Safety Commission. And I want to talk to you just briefly about our tool, the Rapid Effects Analysis of COVID on Healthcare, or REACH, that we use to try and help DHBs understand some of the effects of COVID on hospital activity. So when the pandemic reached our shores, of course, a lot of normal hospital activity got interrupted. A lot of effects on planned activity where elective surgeries and outpatient appointments had to be postponed en masse where that was possible. But there were also quite a lot of changes in the acute care setting as well. And actually that's going to be more of what I focus on in this talk, just because there's not enough time to talk about everything. So when we started to impose restrictions like lockdowns, we saw a lot of changes in public behaviour. And so while on the supply side there was effects on elective surgeries, also presentations to EDs that hospitals didn't have any control over also collapsed. And so we wanted to understand what was going on in that space and who was affected. In particular, where equity gaps might already exist, were they exacerbated either by those effects or by whatever the recovery period afterwards would have looked like. To do this, we first started working with Waikimata DHB, but then we've also looked at the national picture by using the Ministry of Health's national collections as well. And so to talk about this, I think it's important just to have a quick look at the data itself so that we all know what we're talking about. I'm sure we've all seen charts like this quite a few times since the pandemic. But this shows us a fairly long time series over the 5 years leading into the pandemic for the national picture of emergency department presentations. So we can see there's generally an increasing trend through time, a fairly stable time series, one that might be flattening off a little bit leading in through 2019. But then once we hit March of 2021, we see the fairly famous crash of emergency department presentations down to around about half their normal level. And I guess the first thing we would all wonder is, well, who were the people who didn't present to the emergency department? You might think, well, there will be a lot of people who might not present, who might be able to seek healthcare in other ways. And one of the ways that we might look at trying to understand that question would be to use the scale of clinical urgency that's used in the emergency department, the triage scale, which assigns a number from 1 to 5 on the clinical urgency of the presentation. So somebody who has a triage 1 is required to be seen immediately when they arrive in the emergency department. Somebody who's triaged as a 2 needs to be seen within 10 minutes. So these are the 2 most urgent categories. When we look at the same time series for those presentations, well, one, we can see that actually it's quite a steeper increase through time that we see proportionately for those. But when we get to the point of the pandemic, we see very much the same crash that happens there. So when we talk about a change in the emergency department presentations, we can say it's really across the board that those changes have happened. So our way of approaching understanding what was going on in this time was to develop an interactive dashboard that could visualize the effects of the pandemic. So we wanted to create some way of predicting what a normal level of activity might have been in, let's say, an alternate universe in which there was no COVID. So we could predict what the normal amount of ED presentations might have been in through 2020 and 2021, but in the complete absence of COVID. And then we could contrast that level of sort of imaginary normal activity with what really happened during the pandemic, and then we could make sense of the differences between them. And this would give the user, which in our case users at DHBs or the Ministry of Health, the ability to select any patient group that they might be interested in. So that might be a demographic group looking at ethnicity or age or sex, or it could be a clinical group. We talked about the triage codes, which might be one way of looking at that in the ED, but also in hospital admissions, we could look at health specialties. And we also have the ability to look at the admitting diagnoses as well using DRG, which is a fairly granular way of looking at the cause of the admission. And then whatever set of filters that user might apply, the model would then run on the fly, update all its parameters, and then show the new output for whatever cut of the data they were looking at. So to model this problem, we've used an open source tool called Prof that can decompose a time series on the basis of its long running trend, all of its seasonal components that we might expect to see, as well as holiday variation, and then whatever the remaining noise will be. And by feeding it several years of data that lead up before the pandemic period, we can then let it make a naive prediction for the pandemic period. So again, like I was saying before, what the world might look like if there had never been the pandemic. And the handy thing about Prof is it's able to make those sorts of predictions pretty quickly, which is really important for us because we're letting the user here make any cut of the data they might want and run the model on the fly. So it needs to be reasonably quick, and it's able to do that. It's fair to say we are also then asking quite a lot of the model when we're doing that, because it has to look at all sorts of different cuts of the data and be able to work reasonably well across all of those things. Really, really important here, just to talk about what the model is and maybe more importantly, what it isn't. So just to say it again, the model is predicting the level of activity we might have expected in the complete absence of COVID. It is not forecasting what we expect to happen through the pandemic. And it absolutely is not and cannot be used to predict anything around what should have happened through the pandemic. That's not the purpose of the tool, and it's not something it could ever do. So to put that another way, Reach is a tool that's really agnostic about service performance or any other reason that might explain any of the patterns that we see. It's just a descriptive tool telling us about the difference between what really happened and what might have happened in the absence of the pandemic. Another point on that sort of same line of thinking is we'd talk about this as being a tin opener sort of a tool. So something that you might use in an exploratory way to start understanding a little bit of what's going on, but not as a dial sort of a tool. That would be the sort of a tool where you already know an awful lot and you're just trying to fine tune or refine what you understand. So this isn't designed to give a lot of really final answers. This is a tool that's meant to open up some lines of query and see what's going on. And this is what the tool looks like. So up the top, the user is able to select the area of interest, whether it's the emergency department presentations or some of the cuts of hospital admissions. On the left-hand side, they can select whatever combination of demographic and other filters that they might want to apply to look at specific cuts of the data. And then down the middle is the main guts of the output here. So the green line on the top chart here is showing the model's predicted number of, in this case, ED presentations that might have happened again in the alternate world without COVID. And the red line shows what really happened. And then down below that, we can see something that's really just summing up the differences between those red and the green lines. So it's showing us a cumulative chart. We call it the shortfall because the usual pattern is that the real activity is lower than the predicted activity. And what we can sort of see is that there's about 100,000 ED presentations that didn't happen through the pandemic that we might have expected to have happened otherwise. Just to zoom in a little bit on that, this is the same time series for the whole of emergency department presentations. We can see the point in late March 2020 where we have the big crash of ED presentations happen. And then we can sort of look at the general recovery that happens. And we can see that the two lines come back together around the point of it's late 2020, maybe sort of October onwards in 2020, where what was predicted by the model naively is kind of matching up quite well with the actual presentations. And again, to look at that in terms of a cumulative picture, we can see the disparity opens up through this period of time from the initial level 4 lockdown. Then we reach a period where the line flattens off again. And that flattening off is sort of showing that the prediction versus the actuals are roughly kind of equal. And of course, we can see what happens when we get to the Delta lockdown in August of 2021. So that's the picture for emergency department presentations overall. If we just look at those two most urgent clinical triage groups, so the triage 1 and triage 2, the pattern looks similar, but a little bit different. So at that same point in late 2020, where in the overall presentations, things have kind of evened out. When we just look at the roughly 10% of the presentations that fall into triage 1 and 2, level of ED presentations has a long period right through to Delta where the actual presentations are consistently higher than what the model would have predicted to have happened in the absence of COVID. So we see the drop-off happen and then we see an excess, which might suggest people presenting later. But of course, there's lots of possible explanations here and the tool is agnostic about what the causes are. But one way of at least digging in a little bit further, and this is the cumulative chart for that. So we can see the sum of the presentations that didn't happen, and then almost a similar number that really happens in that later catch-up period before we hit Delta. So it's quite a different picture than what we see in the overall ED presentation. But one way of looking at this to sort of see what might be going on is to look at who actually gets admitted to hospital. So this is the same chart, but instead of looking at ED presentations here, we're looking at the acute inpatient admissions. Really, it's the same picture as what we see when we look at the overall emergency department presentations. We have an initial drop-off in hospital admissions, then it recovers the same point in time around late 2020 to about the same as what the model was predicting right through to the point that the Delta lockdown happens. However, we also created a cut of these hospital acute admissions that we thought would be unlikely to be affected by the pandemic per se. So a lot of hospital admissions didn't happen for very good reasons. For example, people in a lockdown are not out driving their car, so they don't have a car crash. Rates of trauma dropped quite a bit. Major trauma radically dropped for the period of the initial lockdown. And of course, as we probably all know as well, on top of that, things like respiratory infectious diseases really did not get much of a chance in the pandemic to spread because of all of those behavioural changes as well. So those sorts of things we would expect to drop off the cliff a little bit. However, when you remove those set of acute diagnoses and look at what's left, we see something that's a little bit similar to that pattern in those triage 1s and 2s, which is to say that once we recover from that initial crash in hospital admissions, we see an extended period where the admission levels are a little bit higher. And of course, one of the first things that we were worried about here was that this could happen because we'd seen overseas that things like people with stroke had stopped presenting to the emergency department, acute myocardial infarction, those sorts of things. So we have looked a little bit closer. The good news here is that when we look at those sorts of groups, so stroke, TIA, chest pain, AMI, those sorts of things, we actually don't see that same pattern. It looks a little bit more like the overall picture. The admissions come back to a normal level. That's not to say, because this is highly aggregated data, it's not to say that there aren't individuals that are affected by that, but the overall pattern doesn't look like that. So where we see those increases, it's in other DRG groups. Unfortunately, one of the limitations here is that when you get into really small cuts of the data, there's a lot of irregular patterns that happen, and it stops being a really good tool to tell you about very, very specific groups. But again, this is a tin opener. This is meant to be opening up a can, and then some more closer clinical eyes can be passed over the data. Another news story is that, broadly speaking, we didn't see evidence of widening equity gaps, particularly between Māori and non-Māori, notwithstanding what Melissa's excellent presentation before said about the quality of some of that data, of course. And this probably reflects that DHBs did quite a bit of work to make sure that in their catch-up phase, they were being really careful about some of those equity issues. And it looks like that probably broadly worked quite well. It's not to say there weren't equity gaps. One of the ones that we did identify was dental surgery in young people, where a lot of dental surgery didn't happen, and some of that has been addressed subsequently by other people. There's lots and lots of limitations in doing this sort of work. You can certainly ask a lot of very sensible questions about really how far can you predict with a tool like this? What would returning to any kind of normal really look like? They're all good and very open-ended questions, and to be honest, there are no great answers to those. We'll only really be able to tell with time what a new normal might look like. All we can do is try and model the best that we can and build a picture off of that. Another limitation is just because of the data sources here, it's not a tool that we're able to share openly or publicly. So it's only restricted, unfortunately, to people that would have access through DHBs or through the ministry. So yeah, thanks very much. Happy to take any questions that there might be.
Tēnā koe Paul, kia ora mō tēnā. Thank you for that talk, Paul. I particularly like the summary or the cumulative graphs that showed the difference between the actual and predicted. And I also like those graphs which showed that the actual was higher than predicted as well. I didn't expect to see that. I also see that we've actually run out of time. So I know that, well, it seems like there are some questions, but I'm afraid I'm going to have to leave those until we're having a break at 10:40. So I don't know if you're going to be available at 10:40, Paul, but if you are, well, perhaps you can answer the questions in the question and answer box, or is that what we can do, Patrick?
Yes, Paul can actually answer the question in the Q&A box at any time.
Okay.
Well, aroha mai for talking for too long. I'll do my best to answer the question.
No, I did enjoy the talk, so thank you very much once again, Paul. And we'll move on now. I'm looking to see if I can see Jesse's. Oh yeah, sorry. Tēnā koe Jesse, no mo haere mai. Welcome, Jesse. Jesse is from the Waikato University, and he's talking to us about spatial equity. Sounds very interesting. Over to you, Jesse.
Morena tātou. I'll try and whip through this so that we can have our morning tea. And apologies in advance. I have my daughter at home watching Bluey, so hopefully you can't hear that in the background. My wife's just come off a night shift, so she's asleep. So I'm trying to balance the right amount of noise and quiet. So yes, I'm a health geographer at Te Nira Institute for Population Research at Waikato University. And so I'd like to share some work around spatial equity and health services in Aotearoa. So today I'll talk through what is spatial equity and how it's measured, and then provide two examples. So one is from GP services in the Waikato DHB region, and this came out of my PhD work, and then a more recent example of COVID-19 vaccination services at a national level. And I won't have time today, but just noting that I've also done some other work with the Southern District Health Board around child and youth oral health services. So this sort of work can basically be applied to any kind of service that's delivered out of a geographic location. So as we all know, inequities are shaped by differential access to the social determinants of health. That's one of the primary pathways, but also through differential access to healthcare. So this is kind of the focus of today's presentation. And I guess in theory, this is one of the pathways that the health system can actually directly affect and improve. So ensuring equitable access to healthcare is I guess a foundation of an equitable health system and achieving health equity. So what is spatial equity? There's various definitions in the literature. We carried out a systematic literature review. And I guess the main kind of group of definitions that's of most relevance to the context here in Aotearoa is a need-based distribution of resources. So essentially populations that have higher health needs should have better access to resources. So equal access can actually be inequitable. And of course, within the Aotearoa context, there's, te tiriti o waitangi as well, that we need to make sure we're meeting those obligations. And how it can be measured. So essentially we look at defining spatial equity. So we've said that's a need-based distribution of resources. The main work happens here in step 2, so estimating access to services and estimating population need. And then you can quantify that through a few kind of statistical techniques. But also it's really important to kind of triangulate those findings and look at qualitative sources of information to kind of contextualize that information. So I guess the easiest way is to talk through an example. So for looking at GP services in the Waikato DHB region, we developed an accessibility index, which is essentially a measure of how many clinics there are in a population, how many GPs there are working at those clinics versus the size of a population, and then it applies a kind of a catchment around that. So it's, you know, how close you are to a service, how many other people are potentially accessing that service, and how big the service is. And that's something called the enhanced two-step floating catchment area method. But basically what you need to know is that darker areas have lower levels of access, and lighter areas have higher levels of access. So on this map, it probably intuitively makes sense. You know, in Kirikiroa, access is pretty good. And on that rural periphery, you know, up in Coromandel, Taumarunui, etc., access to primary healthcare is not as good. The second step is around estimating need. So we actually looked at 7 different potential indicators of need for primary healthcare using different data sets. I probably don't have time to go through each of these in detail, but I'm sure you'll all be familiar with a lot of them. So ambulatory sensitive hospitalizations that can potentially be prevented by primary healthcare interventions. We looked at selected cancer rates, crude mortality, the health domain of Dan Exeter's index of multiple deprivation. Age was defined as the proportion of population in that kind of high user age range, so very, very young people and people aged over 65. The New Zealand index of deprivation, and we included smoking rate, although it's not an indicator per se, it's a health-related behaviour that is associated with poorer health outcomes, and it's actually used quite commonly in the literature. And then we mapped these for the Waikato region. This was before Stats NZ moved to the new geographies, so it's at domicile code and census area unit. And we looked at also how the indicators were related to each other. So if you had to only choose one indicator, for instance, you can see that ASH rates are highly correlated with all of those other indicators. And so socioeconomic deprivation as well is correlated with all the indicators except for the cancer rate. But also important to note is that, you know, as we see in the national data, those ethnic inequities are stark and pervasive. So for area units with a higher proportion of Māori or Pacific people, positive correlations with all of these outcomes were noted, and the complete opposite direction of correlation for neighbourhoods with a high percentage of European residents. So sorry, I'm just moving around this screen. So when you map those indicators across the Waikato region, we applied some kind of geostatistical clustering measures. And so basically the dark red areas are statistically significant high values, and dark blue is a statistically significant low value. So this bottom right-hand corner shows clusters of high spatial access in Kirikiroa and low access around the periphery. But as you can see, for basically all of the other indicators, the almost complete opposite pattern is observed. So for most indicators, you have quite low levels of need in Hamilton, but around the periphery, you have kind of clusters of very high need that have poor access to services. So for instance, I mean, in some places, you know, Taumarunui, that's across 3 different indicators, 4 actually. So that's, you know, an example of the inverse care law. So it's suggesting a spatially inequitable distribution of services where populations that have very high needs actually have some of the worst access to primary care. You can also quantify that through the Gini coefficient, so that looks at equal distributions of resources. So that's 0.47 suggests it's quite unequal. When you look at the distribution of scores of accessibility across the population, it kind of gives the impression that you know, a lot of the population have good access, but it's important to dig a bit deeper and look at who is in that population. So actually, over a third of people living in areas of high socioeconomic deprivation also had poor access to services. And of course, we know that that disproportionately impacts Māori and Pacific people. And so interpreting those results, you know, the Gini coefficients suggest an unequal system. You can look at those maps of access versus need indicators, and that clustering confirms an inequitable distribution and highlights key areas that have high health needs but poor access to services. And bringing in, triangulation. So, you know, of course, there's additional barriers that are not just spatial. So getting an appointment is really tricky. You know, it costs a lot. And of course, you know, the model of service. So if you think about kaupapa Māori services as well, most of those GP clinics are not kaupapa Māori. So that's another layer of barriers on top of that. And of course, the fundamental drivers of inequity for Aotearoa as a whole, but also within the Waikato region, you know, the history of colonisation, violence, the intergenerational trauma, and, you know, ongoing discrimination and racism within the health service. So just quickly, I think I've still got a bit of time. I'll try and go through another example. So looking at COVID-19 vaccination services. So before the rollout, I thought this was probably an opportunity for, you know, developing an equitable service distribution. We're starting from scratch. So I looked at, so we've done 2 papers around this work. So one was around looking at before the rollout, would access be equitable for priority populations? And then kind of after the rollout happened in August 2021, we looked at, you know, what was actually happening at the time. So essentially it was around, you know, following a similar approach, looking at whether people were, and especially priority populations, you know, Māori, Pacific, older people, people with underlying health conditions, then mapping the vaccine delivery sites and identifying who had poorer access to services. So we, you know, took the same approach to estimating access to services. And this time we used data from HealthPoint to look at mapping all of the vaccination services for the country. So again, you know, similar kind of maps. The Gini coefficient suggests an unequal distribution. You can see lots of areas of dark red of poor access, particularly in rural and remote areas of Aotearoa. But also, you know, within DHB regions. So I'm kind of Waikato centric, but, you know, Hamilton has really good access, but what about the surrounding areas? And then we looked at access for specific neighbourhood types. So areas with a high proportion of Māori residents actually had worse average access, worse than the total national average. Similarly, for areas with a high proportion of older people, worse access to COVID-19 vaccination services. Oops, and I've skipped to the next slide. It was also important to note that access was better in some DHBs, and this seemed to be associated with more equitable uptake for Māori. So there was a strong correlation between average accessibility for a DHB and vaccination rate ratios for Māori. So again, a huge table that I won't be able to go through in detail, and I'm getting the bell. But for example, Capital and Coast DHB had very high access, similarly Southern DHB. very low proportion of Māori living in areas with poor access to vaccination services, and a quite high Māori vaccination rate ratio. On the other hand, kind of Lakes DHBs in Northland had very low levels of access, a very high proportion of Māori living in areas with poor access, and very low Māori vaccination rate ratios. So in summary, during the Delta outbreak, the services were inequitably distributed, and there was worse access for Māori Pacific older people in rural communities. And of course, you know, again here, there's other layers of information there that we need to consider. But overall, you know, one cause of health inequities is differential access to care. Spatial equity is one way to kind of monitor how we could be doing better, and is potentially modifiable by the health system. So I think we could and should be doing more to plan our services equitably. And hopefully I've got a bit of time for questions. Thank you.
Tēnā koe, Jesse, ngā mihi kia koe mā tēnei kōrero tino whakahere. Thank you, Jesse, for this presentation. Thank you very much for this very important work you do. I found your presentation very clear. I thought your explanation of the geospatial terms, which I didn't know a lot about, I think that was very clear, and also your explanation of statistical terms like the Gini coefficient. I thought that was very clear too. So thank you very much for this presentation. Patrick, can you help me with questions? Are there any questions?
Yeah, we've got one from Dufford just come in.
Kia ora, Jesse. Thanks for your interesting presentation. The question I've got is, you know, the analysis you did around access to services for vaccinations, were you able to feed this into the vaccination rollout?
Yeah, that's one of the key challenges I've been finding, especially I guess sitting within a university, is that you know, you kind of produce this research. You know, I did share with the Ministry of Health, but it's hard to know how much that gets taken up and acted upon. I guess at the time as well, you know, there were 20 different DHBs kind of shaping their own rollouts. So the Ministry of Health would kind of say, okay, that's great, but we can't tell the DHBs exactly what to do. And I guess it kind of raises something that I've been thinking more about, is potentially there's a lot of opportunity for more collaboration between kind of public health units or intelligence within the government and universities. And, you know, we kind of see doctors, for example, work within, you know, hospitals and the university, and maybe there's a space for kind of academic researchers to work within public health units and the university and kind of draw on those skills, but also influence change at the same time.
Yeah, I fully agree with you on that last point about developing closer links.
And that's not just a self-promoting pitch to get a job. But, you know, I think, yeah, I do think, you know, there's opportunities. There's all these skilled researchers sitting within universities that want to make impacts, but sometimes struggle to realise that.
Okay, we have another question from Ellen.
Hi, thanks for the talk. I guess you did kind of your mapping on top of the health point stuff for vaccinations. Do you have any plans of kind of extrapolating that out to other service providers such as GPs and the likes? And do you think the model would work well to display kind of access to healthcare in other settings other than the vaccination rollout?
Yep. So if I've understood your question, you're asking if you could apply this kind of approach to other health services.
Yeah, correct. Yeah.
Yeah. Yes, I think, I mean, it could and probably should be applied to all, you know, health services that have they're provided in a specific location. You probably need to think a little bit differently about some types of services. Like, not every town can have a neurosurgery department, right? That's not realistic. But, you know, for a small country with limited resources, I think we need to think a bit more critically about how and where we're delivering services, and possibly the kind of new health structures that we have provide an opportunity to do that. So yeah, I would like to do more of this work. Again, the challenge with the university position is you do the work that you're funded to do. So it's, yeah, I can't just go out and do whatever I want. I can see Chris has got a question. Maybe I'll just pivot to Chris quickly.
Hi, Jess. Thanks for that. It's good to see that Waikato is still pushing the accessibility problems in health. I think that needs to be continually highlighted, and I think you've done a very clear and straightforward job. So I'm sure that people are at MOH are listening and are looking at this kind of information. I might have missed it because you went fast on one slide for me, but are you able to tease out the impact of car ownership on this? Because New Zealand's such a car-dependent place.
It's a really good question. So I didn't go into all the details on the accessibility model, but yeah, it was based on estimated drive times. So that's, you know, assuming that people have access to a car. I did get in touch with someone from a GIS company, or they got in touch with me actually, and they said, hey, we can look at cycle times or public transport times in those accessibility models. And I think, you know, it would highlight those issues even more, because, you know, a lot of those rural communities, you know, don't have a bus route, and if you don't have a car, you're kind of stuck there with no way to get to any health services. You know, also kind of children can't drive, older people often less comfortable driving. So yeah, I think that's a really good point. And there's lots more kind of detail and nuance that you can dig into.
No, it'd be interesting to see that, and it kind of means that any identification of inequity is probably a conservative estimate, because they're the people least likely to have access to a vehicle.
That's a great point. Yeah, I would agree with that.
Okay, cool.
No mai hoki mai. Tēnā tātou, no mai hoki mai. Welcome back to our conference. We've just had a break, and it's time to welcome the next speakers. Tēnā kōrua ko David, ko Alex, no mai hoki haere mai. A big welcome to David and Alex, who are from the Waikato Public Health Unit. And congratulations on such a stimulating title, Data During a diSARSter. Over to you two.
Nā mihi, Peter. Tēnā koutou katoa I tēnei rā, ko David Thomas toko ingoa. I'll just share my screen. So I'm the Public Health Intelligence and Policy Manager at the National Public Health Service now at Waikato. And this presentation is about our experience, the Intel team's experience in Waikato during the pandemic, or as Peter's pointed out, data during a diSARSter. I will start the presentation and then hand over to Alex, and then I'll finish off. Before I start though, I'd like to acknowledge Ishani Soisa and Mike Kean for their input into this presentation, who have been along on the journey with us. We'll start in the beginning, if you can remember that far back, March 2020, before COVID. And then we'll look at the intervening time before Delta and what we did, including the impact of the cyber attack at Waikato DHB, before going on to the Delta and Omicron responses, and finishing with what we consider some of our successes and some lessons we learned along the way. So you'll see in the top right-hand corner a graphic showing our sort of progression, the key moments for the unit in the initial wave. It highlights the cases we're having and key time points in that process of that initial wave. So the team fulfilled the intel function for the PHU incident management team. And we also became the intel function for the DHB in terms of a view around the current situation on cases, contact tracing, which was going to inform the testing strategy. The Mahi was very manual in this initial phase, with us working with and dealing with a lot of raw data, with significant quality issues around ethnicity, timing, currency, missing data and duplication. And for this took up quite a significant amount of time for the team. The data sources were problematic as well. We had multiple systems recording slightly different views of data. We had manual notifications, faxes, BPAC, IPM, EpiServe, RedCap, and so on. But despite these issues, we wanted to provide as much access to information as we possibly could to the people within the health sector and also our partners in the community. So we developed a dashboard, as you can see up here in the top right-hand corner, which shows the total of cases by territorial authority. We also had testing information. We had different views in the bar graph down the bottom, and we also had a mapping view to give a spatial view of what was happening at a small area level. And in order for us to produce this dashboard and the SITREP, we had to reconcile all the data sources, which was quite a time pressure daily occurrence for us. And it limited the capacity of what we could actually do due to this reconciliation process and data quality process in what was a already small team operating on a 7-day roster. But one thing we were able to do with the dashboard was provide access, a password access to iwi, so they would see in terms of data, in terms of cases and testing information, they were getting the same view as what the DHB was getting. Moving on then, after the initial wave, in the intervening time, we looked to develop a ClickSense dashboards to look at seeing what was happening in managed isolation, as well as the proposed case dashboard for the next phase of the pandemic. We also worked in partnership with our iwi and Māori providers during this time, providing intel around COVID testing and over 65 years old flu vaccination at the small area level, and shared this information with them so they could inform their testing strategy and their mobile testing and vaccination teams, and highlighting areas where we needed to increase access to testing and vaccination. Also, during this time, the unit appointed Māori and Pacific people public health advisors to work in the COVID space, and this greatly enhanced our responsiveness to iwi and Pacific providers. And then after all this mahi, in the intervening time, the cyber attack hit the whole DHB in May last year. And while our development around ClickSense had become problematic due to varying factors, not least not having access, back-end access to the data in NCTS, the cyber attack finally put the nail in the coffin, if you like, of our development around these sort of solution to provide an external view of data, as we were locked out of our environment, of our development environment. Also during this period, after the cyber attack, we made the decision to move towards open source tools, and we thought about having our own server to develop the processing, to have the processing capacity, but due to the cyber attack, this wasn't an option. So our solution for this was to just buy high spec machines for the team to have that capability locally. And I'll hand over now to Alex.
Kia ora. Ko Alex Brebner tōku ingoa. I'm currently the public health reg in the Waikato Public Health Unit, but was the public health intelligence officer during these Omicron waves. So eventually Delta hit. Just move on. Next slide, please. So RH in his talk the other day mentioned being nimble. So our interpretation of that is, being agile, and we decided that trying to continue with the click dashboards was really not the best way forward, because our development was quite slow, because we were quite inexperienced, and there's also problems with getting licensing and distributing the data to the right people. Next slide. So instead of a dashboard, we moved to a daily sit rep, which we decided to build in Python, which gave us a lot more flexibility in what we could do. So that essentially just would spit out a Word document with all the relevant information that we'd compiled. And this allowed us to really build a much more complicated system, because we could automate a lot of the tasks. Next slide. So some of the challenges we faced, firstly, we wanted to make sure we had an equity focus on all our reporting. And so what this looked like was that we would report on, we prioritize reporting by ethnicity on as many measures as we could. And we would prioritize responding to the Marangai Ariari, who are our Māori health response team for COVID. And then also responding to our Director of Māori Equity and Health Improvement and our own Māori and Pacific public health advisors. One of the problems we had was data access. We really only had access to the front end of NCTS to get all of the COVID data out, and it's quite limited what you could pull off. So using Python allowed us to semi-automate that, so we could pull a much larger range of data than we otherwise could have. As alluded to before, we had problems with licensing costs and restrictions getting licenses for people, and so in the end that contributed to our decision to try and move open source. So we moved from Click to Python, and have even moved from ArcGIS for our geospatial to the open source platform QGIS. Another issue we faced was that when we first started, it was very much an operational sit rep designed for the public health unit. And over time, the distribution list got more and more as more people wanted access to the information. So we had to balance privacy versus detail. I'll just skip the next bit. So next slide, Duff. Some advantages with Python is let us integrate a whole lot of different data sources, so we could produce more in-depth analysis, and it allowed us to work better. We could automate the mapping, and we could have a wider selection of analytical tools at our disposal. And for our team with our skills, which is a pretty modestly sized team, it allowed for more rapid development than if we had used Click. Next slide. Another problem we faced, and I'm sure many people had this same experience, was that every day everyone would report different numbers, which was very much due to there were multiple data sources we could use, EpiServe, NCTS, or our local records. Everyone would report with different time frames and have different definitions of sick laughing face coming up. And the other problem was address hell, that people could live in one place and get COVID in another place, and so the definition of who was where was very well. You couldn't match up with other people. Next slide. Another definition of agile is just responding to the whole time we were responding to smaller requests alongside the daily report, and a lot of operational requests. Trying to say, for example, searching through all the test results to try and see who in ARCs had been tested and who was positive. Next slide. Then Omicron hit. We knew that there was going to be an impending collapse of our system because we couldn't pull the data down as the numbers got larger and larger. The download times would get too long, and NCTS has a limit to how many rows you can download on any Excel sheet. And of course, Excel only has 1 million rows available anyway. So we knew that was coming, and we were pushing for back-end data access, which thankfully that project got taken over by the COVID-19 directorate, which got set up here, and then eventually they took over the reporting to the wider DHB. Next slide. That allowed us to pull back on reporting. We've just changed from a daily report to a weekly report. And we've just leveraged the infrastructure that we'd set up on Python to do that. Next slide. Can probably skip this slide, Dov. I think it might be back to you.
Hey, thanks, Alex. So looking at some of what we thought our successes and some of our lessons, we were able to provide access to iwi in the initial wave to the dashboard, and later when we couldn't do this for various technical and organizational reasons, having the Māori and Pacific Peoples public health advisors working alongside, side by side with us, they were invaluable. They acted as our connection to iwi and Pacific providers, but also were able to provide feedback and work with us in terms of what iwi and Pacific providers wanted in the information we were providing. We also found that we would like to see systems that record iwi affiliation. In our experience, we were often asked for this information. And it's invaluable in terms of benefits it gives further down along the process from a Manaki point of view, as well as reporting and operational points of view. We need access regionally. We need access to the full picture. Communicable diseases don't respect borders. So if we are restricted by an arbitrary boundary, then we're not fully informed. And this second point is crucial for us to be able to have back-end access to do so much more with the data and information. We're able to do more sophisticated analysis, but also link up with locally stored information. And just quickly around people, funding by year is not sufficient to attract heaps of good people. There is a significant gap in training and as well as analytical and intel standards. There needs to be dedicated funding to develop people. Also having a clinical person in the intel team, by the way, if you hadn't noticed, it's Alex, was invaluable to have on-demand clinical perspective, especially during a fast-changing environment. And also through a combination of various factors, not least each outbreak being different and us having issues with the infrastructure, the ability to remain nimble or agile is vital and to remain so. And then with our move towards open source tools, having development capability in the team is essential, as that also allows us to be nimble. Ngā mihi nui.
Tēnā kora ko David Phillips, ngā mihi kia kōrua. Thank you both for the, David and Alex, for this very enlightening presentation. It's always good to see how people display things differently and see a different view of the data. I wasn't aware that you guys have had a cyber attack, and I didn't know. You know, you hear about those in the news, and you don't know how if they actually affect you, but it looks like it does affect health in New Zealand. And I'm very pleased to hear. It was very nice for me to hear that you're working with Māori and Pacific providers and iwi as well. So thank you very much for this very enlightening talk. Thank you very much. Patrick, do we have any questions?
Myself? Yeah, we do. We've got a few in the Q&A, which Linda's can choose to answer right now or just in writing whenever. Two questions from Alison, which I'll hand over to David and Alex to answer.
You know, there, in terms of why the Ministry of Health didn't provide dashboards, you know, to be fair to them, they did. But the level of detail on the regional level was, you know, what was provided at the national level was at a regional level, you know, at the DHB level. For us to have good use of that operationally, we need a smaller level view of the data. You know, we were showing our information at SA2 level. You know, it was in, you know, the dashboards we did provide, it was, you know, a restricted access. So, you know, there's issues around privacy as well.
The other thing I'd say is we also are just providing a lot more operationally orientated information, which the ministry can't know. So it's kind of a necessity for us to be doing this.
Kia ora anō, ngā mihi kia kōrua. Thank you very much for those presentations. I'm going to move to the next speaker now, but we do have a break afterwards at 11:40 where we can re-intervene with questions and answers again or take an extended lunch. But right now we'll move on. So ngā mihi kia koe Uli, nau mai haere mai ki tēnā hui o tātou. Welcome Uli to this conference, and thank you for deciding to present to us. Uli is from the EPI Interactive Organisation. I don't know what that is, and he's going to talk about dashboards. So nau mai, Uli, over to you.
Kia ora koto, kia ora koto, and yeah, very warm welcome and thanks for the opportunity for this talk. So my name is Uli Muellner, I'm director with EPI Interactive, and we are a private organization supporting the health sector, and we are based here in Wellington, New Zealand. So thanks for that. And yeah, so in this talk, so it's a bit more generic title, what's in a dashboard. And we like to dive into a little bit the tool set we have available and what's the right tool for a specific purpose. And I'd like to dive a little bit into the approach we take. So we quite like to work with open source technology, and in particular with R and Shiny for dashboard development. And so for us, it's important to connect with our audience. Dashboards always have a certain purpose, and we like to connect to our audience as well as possible. Before I really dive into that, I'd like to big thanks to the organization we worked with over the last years and who made kind of the outputs I'm gonna dive a little bit into possible. And so when we look into dashboarding tools, there's a wide range available. So can broadly split them up in out-of-the-box tools, so point and click. So you know the names, so that's so the more well-known ones and widely used ones are Power BI, Click, Tableau. And then the other world, we heard in the last talk already a little bit about it, so is the scripted or code-first approach. So tool set is typically in our space or Python for analysis of health data, but it also then drifts into web technologies, for example, JavaScript frameworks, and then the more traditional programming languages. When we look at the different tools, so one way to look at this to look at the people actually using it and what is fit for purpose. When we look at the more out of the box tools, so it's the business users who can do it. So it's relatively approachable. I can learn it without any programming experience, and I can very quickly produce dashboards. Then when we go to the analysts, so they also like to use with out-of-the-box tools for quick analysis, and data science space as well, but then it already tends to go into more of a code-first approach. And then when we go down a little bit to researchers and then programmers, so again, another tool set. So we think there's a bit of an overlap with R and Python, but programmers then prefer the more web technologies or traditional programming frameworks. Now the tool set we tend to use, and so we specialize a little bit is R and Shiny. So a lot of you guys probably already know about it. So it's already around for over 30 years, developed originally in New Zealand. And it's an open source environment for statistical computing and graphics, and well integration of also data sources and analytics. Then Shiny is a specialized web framework on top of it. So relative young technology, was around 10 years old, and sole purpose is to bring our outputs to the web and to create interactive data visualizations. It's maintained by RStudio, and these are open source technologies, so they are freely available. So what do we like about it? So as opposed maybe to the out-of-the-box tools we have available. So it is once you are, let's say, an analyst or a researcher, it is fairly accessible without having a programming background, and it's also widely used and taught. So especially University of Auckland, and also when you look at grades from Big Uni, so it's well embedded in their curriculum. So if you're looking for staff with this knowledge, I think it is already widely used, and people understand it. Also, when you look into sharing your outputs, it's open source, it's free to share, there are no license costs attached to it. So that makes it easy to provide that transparency, and it also provides a lot of specialist packages So also for niche use cases, and like in our space, we easily drift into those niches as well if we want to analyze our data in the health sector. What we also quite like about this is that extension to with common web technologies, so you're not stuck in the technology and the framework. It can be extended towards in particular to those general web technologies. Yeah, so I just put a bit of an opinionated collection of features in it, which support that code-first approach for dashboarding and data visualization. So I've got a screenshot of Coupe there. So we initially developed it with the health promotion agency, so that's now integrated into Health New Zealand, but it's a survey. The dashboard displays survey data of the health and lifestyle survey, and so it is a really dedicated interface. It fits into the other tools they have available, into their branding they have, and it's very specific to the data that is available. And since we originally produced it, so there were a lot of additions to that. So it was actually great to see that as a bit of a living project, and which constantly features are added or new data gets integrated. So with that one in particular, we could also support mobile devices, and yeah, so we could easily embed actually, or other data sources could be embedded as well. So custom interfaces. Then another one is, I think that's a big one, is freedom from reporting. So often frustrations in an organization is that you got to write reports all over again. So maybe it's a yearly task, but then it's a process from analyzing data and then writing reports. And so with the example I show you here with Cancer Care Data Explorer, so it's a dashboard, and it drills into different cancer groups and indicators and measures, and I can analyze the data. But then I can also, where you see that little blue area to the right, so we integrated a link with GoToPrintView. So what the print view does, it collates the data that is specific and the outputs that are specifically shown for the filters I've chosen, and compiles that into a nicely formatted PDF report. So I've got a screenshot for that one. So it's almost like somebody would produce a report manually. Of course, the written context information still might need to be fed in, but sort of it provides something to take away, and it provides detail that is hard to achieve in a written report, because it is really specific to the data the user has chosen. So the other area which sets maybe the code first approach apart from those more out of the box tools is it allows you to add, so what we call add-ons, freebies, or often lifesavers. So so one of the tools we regularly integrate in our dashboards are image exports. So you can click a button, you can then export the chart as an image and reuse it in PowerPoints, and we can add then things like watermarks to it. We can add a date when it was exported, and organizations' logos, and so on. So it's a nice feature to reuse outputs, and then also access to data tables, so different views on the data, and also then methods to export the data, for instance, in CSV formats. And we typically put quite a bit of thought in it, so that we have a meaningful header to it, which shows the organization data, the filters chosen, and we can construct the exported data in a way that is really meaningful for the audience. So lifesaver we recently came across in a project with the Western Canadian Animal Health Network is, so as a little bit of a side product of a dashboard project we did for them, we noticed that they had a really tedious data extraction process. So they were provided with laboratory data that was voluntarily provided in form of PDFs. And it was a really painstakingly tedious process to extract the data from the PDF reports into spreadsheets or a format that where you can use for your analysis. And we then had a bit of a look around. So there must be a better way to do that than doing it manually. And there is an R package that's called Tabulizer. And so that allows you to pass through PDF reports and then extract that in a structured Excel spreadsheet. So you see that a little bit to the right. And so it's all those little lifesavers you can then also produce along the way to make your life easier. So with Code First dashboards, it's not often it's not just the dashboards and preparing the data leading up to it, is then implementing full data pipelines. So so the AS Aquatic Invasive Species Explorer we developed for the University of Minnesota is one example where we implemented a full data pipeline. And so the tool visualizes infection status of the water bodies in Minnesota and provides the decision support tools to prevent or minimize the spread of aquatic diseases. So what we set up for that one is data pipeline where we utilize cloud resources. And so we set it up on AWS. AWS is one of the big cloud providers. And so the pipeline runs, so we check the data on a daily basis from the DNR, so Department of Natural Resource website, where we get the infection status. And then, so once that, it's a spreadsheet that is published here, once that's updated, we actually dynamically spin up a processing server and we run the model, and that takes a little bit over a day. And then once that ran through, we shut the server down again. So that's dormant, so, and it doesn't produce any hosting cost. We export outputs then to the right into a Shiny app. So, and then there are other processes along the way, for example, email notifications, so that we can monitor the pipeline and how it runs. So it's definitely capable to really go full blown with an automated pipeline and model integration. Then another example is, or another capability is the combination to advanced analytics. And example is a dashboard we created in collaboration with McBride. So that's a laboratory in the UK. And yeah, speed up. It's the second to last slide. And so so it's to support global surveillance of foot and mouth disease virus lineages, and it's a highly specialized tool where we integrated APIs for genomic data processing. So just show you a couple of slides for it. So it follows a step-by-step approach in the user interface, and where you upload the data, you can check the sequences, and the process validates if you have uploaded valid sequences and how and where the genome is located. And then you can, at that point, we already matched to the existing genomic database of McBride, and you can mix and match the sequences you can then use for the tree generation, and you can then also interact with the tree. So for example, color tips by country, region, or year, and so which helps you with your analysis. Yeah, so just a quick overview of our approach to dashboards. We believe there is not really the right tool. It really depends on your on your use case. Dashboards are often just the start, and then you got to think back to the data you get, data pipelines, how often you want to update it, and so on. So it often leads to a bigger discussion then. Different delivery modes also. With the dashboard, it's often a pull method, but there are also other methods you can do with reporting. For example, when you use our Markdown, where you can push actually reports to a mail list. And we think UI, UX design is key so that the interface really connects with your audience. And that is really one of the big pros for Code First and Coded Dashboard, for example, with our Shiny. Cool. Yeah, so that was it. Thanks for listening. And I think we have a bit of time for questions.
Tēnā koe rui ngā mihi ki a koe, ka tahi te kōrero te marama. Thank you very much, Louis, for this presentation. Thank you very much for this very clear and informative presentation. I really found this quite hands-on, and it's something that, you know, you introduced us to different tools that we could use, like Kupe and the Cancer Explorer and the AIS Explorer. And I also really liked how you explained what was good about some of them. So thank you very much for this very informative presentation. Can I please start the first question? Do you have a favorite, so like Shiny, one of those explorers? Do you have a favorite one that you like most of all, or that you find easiest to use?
So from the tool set?
Yeah.
Yeah. Yeah, so we work with our Shiny. So we do a lot in our Shiny because the people we work with analysis, there is often already R code available, or models are coded in R. So there is already, people are in a way already familiar with it. And then we can build on top of it. And it integrates really well when you then use our Shiny, and our Shiny is just another R package. So we quite like that integration, and also the flexibility, like I think I mentioned it at the start, that you can build up interfaces. You're free to build up interfaces almost like you want. So everything what's almost available on the web is available in combination with our Shiny, and that customizability of the interface, I think is something we really like, and why we kind of chose that as sort of our core technology.
Patrick, is our next speaker not presenting now? Is that correct?
No, they've had to pull out due to family illness, so they're not going to be joining us today. So you can extra 20 minutes of lunch instead.
Yeah, and please, if there are questions, please come forward.
This is Petra Müller speaking from EP Interactive. I just have a quick response to a comment from Vladimir in the Q&A, because, you know, he talks a little bit about his frustration to get support. So this is actually something we do a lot, and we've organized an R exchange for the last 2 years for here in Wellington, which some of you here in the meeting, I think, actually attended. But I think this is one thing we're trying to do to support a little bit the community of our users here in New Zealand, because when we work with different people, we often run into the same problems. So it's been a really great opportunity to connect people. So if you have these problems and are unsure, you know, we're happy to maybe create linkages with others, you know, to help the community a bit, you know, find ways forward. It takes a bit of negotiations, but so far we've been successful kind of like breaking through those barriers talking with IT departments and things. Thank you. Yeah, Uli laughs, it's a hard word, but but it can be done, yeah. Thank you.
Can I, one word. The problem is about the sensitive data moving. So when I was requesting that virtual server facilities from my local IT, I definitely considered that by default, I have right to use that virtual machine with this potentially sensitive data like COVID and so on. And that was the main question, which I think where all my efforts failed. Thank you. I need to think about that in the future. Thank you.
It appears that we have no more questions. Or do we have any more questions? Oh, the red lights come on.
All right, a question from Anonymous. Do you have any advice for improving the performance of the dashboards?
Yes, so good question. And so maybe specifically to our Shiny, it's so that really goes into how you host our Shiny dashboards. There are examples out there, and when we host dashboards, so we can make it available for like hundreds or thousands of users. And so our Shiny is definitely able to scale, and that is used in production environments, and so we host it on a regular basis for our clients. So what we do if we have a more computational intense dashboard, so we provide dedicated hosting. So for example, on AWS or Microsoft Azure, and we provide dedicated resources. Now you can scale it up. So when you use things like load balancing or Kubernetes, where you distribute the load and the users that are coming in, and you can assign resources to specific processes. So you can scale up the infrastructure, but you can also fine tune the app itself and the programming code. And you can, so in the new version of our Shiny, so you have things like caching available, so where you can store away frequently used subsets of the data, and that speeds up the Shiny dashboard. And how you program it can have a huge impact on how fast the dashboard runs, so that you don't load all the data up front, so you load it subsequently while the user goes through the dashboard. So that's another approach. So we will probably start in fine-tuning the dashboard when we speed it up, and then once you sort of get to a point where you can not where you can make it any faster, then it goes towards the infrastructure. So probably two sides to look at it when it comes to performance and scaling up our Shiny apps.
Ngā mihi anō ki a koe, Uli. Thank you once again, Uli, for your presentation. I see there's been no questions coming forward. What we might do is take an extended lunch break now, and because our 11:40 presenter unfortunately can't make it, so we'll take a break now, and we'll be back at 12:40. Tēnā tātou, nau mai hoki mai ki tēnā hui o tātou. Everybody, welcome back to the PHONZ virtual conference. This is day 2, and we're just starting the after lunch presentation now. The next speaker is the one and only Mr. Len Cook. He needs no introduction, but I'll just read out a few of his things that we can say about him. Former government statistician of New Zealand, national statistician of the United Kingdom, Register of General of England and Wales, a life member of the Population Association of New Zealand and the New Zealand Statistical Association, elected companion of the Royal Society of New Zealand, and also has many honorary academic appointments at the Australian Institute of Technology, Otago University, and NIDA, National Institute of Demographic and Economic Analysis. And last but not least, fisherman extraordinaire. Welcome, Len. Over to you.
Kia ora tātou. Thanks. Thank you, Peter. Now, where am I? Click that. Yeah. What I'm going to talk about, in a way, is sort of a retrospective look at statistics through the eyes of an anthropologist. And I sort of got into that in a little book I read a wee while ago by Jeffrey Rice, as a historian, who really revisited what we thought about the impact of the 1918 flu epidemic. And as you'll appreciate, most of my life has been dealing with survey designs and well-constructed statistical frameworks. And yet, in fact, a lot of the stuff I do now in looking at analysis of justice data, for example, I think gets you into being a bit more like an anthropologist. And it's not that you're without an intellectual framework, it's just that the information that you get doesn't come along in a particularly ordered fashion.
Hi, Len. Sorry, we're getting a few people asking if you could put your slides into full screen, please.
Oh, good heavens. Where am I here? No.
So if you go in the ribbon at the top, click on slideshow.
That's it.
Right.
That way.
Yep.
Most of what I've been working on lately is, however, looking at prison statistics. And a huge amount of what we do in the justice sector looks at prisoners and prisons. And I guess my first comment is that evaluating the justice system by analysing prison statistics is like driving a car through the rear vision mirrors, because there are so many things happen in terms of apprehension, the sort of offence things that we define as offences, how the police operate, how the judiciary operate, parole boards operate. That in fact, we can often be a little bit deceptive. The second thing, I place a lot of emphasis on looking at Māori as a distinct population. And the third thing is I analyse populations, not prisons. And why I think it's particularly important with Māori is that their demographic dynamic is so vastly different from the European demographic dynamic that if you don't extract it and look at it distinctly, then you're bound to end up with rather glib and simple conclusions. And my final point is, in looking at disproportionality, I've gone back to Florence Nightingale and her measures of excess, and arguing that, in fact, simply looking at disparities really dilutes a sense of the significance of disparities themselves. You might recall her own wonderful comment that a young man in British Army barracks had twice the chance of a normal British citizen of dying of infection. And then she said it was like taking 1,009 young men, lining them up on the Salisbury Plain each year and shooting them, which was a not much more effective way of describing it. Here's the mix of prison. This is how we normally analyse our prison system, and you can see that the ethnic mix has changed, that there's a decline in the number of people in prison, but it doesn't tell us much about the generational impacts and, in fact, when they were significant. What I've done is firstly, I went back to the ground floor of Victoria University and extracted all the prison statistics from 1910, which it's impossible to find in any government data archive now. And this is just what actually happened to Maori males in prison. You can see by the time you got to 1982, when we were putting an extraordinary share of young men in prison, the average age of prisoners popped down to 22. It's now gone up to 34. And you can see this extraordinary pattern of just the age mix of the population, and also peaks and troughs, and when we decided we would take more or less interest in young men. If we look at the non-Maori prison figures, they're a little different, but the peaks are roughly in the same place. The impact on the age distribution is somewhat similar. However, what I have done is I then calculated the age-specific imprisonment rates of males in between all of the age groups that you can find in our published statistics. And what you can see here, for example, is in 1971, we put basically 11%, or 1 in 9 Maori males between 17 and 19 in prison. It then fell, it declined to around 4. And here you can see even in 2006, we were still putting 1 in 30 young Maori males in prison. What's happened since? In this decline that's occurred, we are now putting fewer young Maori men in prison, or the rate, which is about 0.2%, is less than any time since the Second World War. Now, if you can find someone in the justice sector that'll tell you that, you'll be rare, because people don't do that sort of quite simplistic analysis. And as you know, it's sort of gone out of fashion to look too far back than Google does. But if you look at this, you then look, we can see the same is happening. In that period, we were pretty tough on young men under 25. But the rates just rocketed up. I'll just go back to that for a second, though, that it's useful to see that until 1956, up to then, we really didn't put young Maori men in prison at a particularly high rate, and then we accelerated it. You know, you've got things like Mazengarb report. The same thing happened with Maori males 20 to 24, only this group stayed high right through. So the rate of imprisoning young men 20 to 24 was pretty much the same for over 30, 40 years. And these, of course, are prime parenting ages. And again, that rate has fallen to a level that you have to go back well before the Second World War to see. If we then look at 25 to 29, and lo and behold, that had a peak again in 1971, and that peak carried on further. And again, this is putting 3.5%, or fewer than, or more than 1 in 30 Maori males in prison for that whole 50-year period. And again, we're just starting to see a marginal decline in Maori males 25 to 30. You then look at 30 to 39, and lo and behold, this rate, if we leave the aberration of 1971, the drop-off was 86, and then as the cohort that ended up in prison in the early 1970s at that extreme rate, reached 30, then of course the 30 plus age group increased its rate of imprisonment. And again, in 21, we're seeing a little bit of a drop off, but basically this is 1 in 40 Maori males, 30 to 39, have been solidly imprisoned for nearly 30 years. If we then get to the next age group, which started rising quite much later, in 1996, it started to rise when that cohort of the early 70s that we put into prison at extreme rates, it reached the age of 40. And here it is, and it's merely wobbling around that level of about just over 1.5%. The interesting thing is when you look at the numbers of Maori in prison, whereas if I go back to 17 to 19-year-olds, you can see the number accelerated radically over a 10-year period, and a little bit for 20 to 25-year-olds, but the numbers of the older age groups, the actual number didn't really accelerate. So what we were doing between the 60s and 80s is concentrating on bringing young men, Maori and non-Maori, into the prison system. We of course did this also in child welfare, and I can show you that shortly. In my muddling around and looking more, sounding more like a sort of a slightly disorganized amateur anthropologist rather than a statistician, in fact, I would argue that for the last 100 years, there's really been 4 stages of dominating Maori male imprisonment. The first is from 1910 to 1960, when we had periods when Maori migrated into the towns at a larger rate, and that increased the number in prison, but it was still just, it was basically growth by the prisoners by the related to growth in the prison population. In the 60s to 80s, we had an extraordinary build-up of Maori young males in prison. 7% were in childcare, 2% of Maori girls, 1% of non-Maori boys. We then went through the 80s to 2005, where we seem to have had a bit of a regret at that. And in fact, many of the things that were offences in the 1970s stopped being offences by the 1980s. And right through until 2005, the main growth in the prison population came from the people that were already there, virtually, that were ageing. And until Phil Goff came along as Minister of Justice and had to have reason to build us 4 prisons, around 2000, we suddenly started putting more people in prison. And then since 2005, there's been this persistent reduction in the rates of state custody for young men. The interesting thing is disproportionality is still the same. Whether the rates are going up or down, we still put between 5 to 7 times more Maori in prison than non-Maori. Just a little bit, and looking back in history, it's interesting that if you take the 4 generations born before the generation which is now having a very much lower rate in prison, when you look at the flu epidemic, when you analyse Jeffrey Rice's study, Maori died at 7 times the rate of European. That in fact 4.9% of the Maori population, but he also noted that it was mainly young men and young men between 25 to 45 that were affected. If you then take a parallel and you look at the Maori battalion, in the 28th Maori battalion, 4.7% of the eligible Maori population, and I've used 15 to 34 in the 1936 census as that, actually died in the war, and 17% of that same population were injured, 4 times or more the non-Maori rate. In the 60s to 80s, as I mentioned, we took the 3rd cohort and put them into prison. And then in the 80s and 90s, 42.8% of Maori male were unemployed in March 1981. So we've had 4 cohorts in a row that actually were quite seriously affected by either major events of the sort that we're not actually seeing now. Now, if we then look at the Maori age distribution, what you can see here, 1966, when a lot of this was happening, 50% of the Maori population was under 15. And family sizes of 6 were the norm. The average number of babies a Maori woman had completed fertility was 6. So we actually concentrated our imprisonment on a population that was both very small, extremely young, and we chose to incarcerate it at quite great rates. Just interesting, when we look at what's happening now, of course, the population dynamics of Maori are telling us that this age group of 0 to 4 is still rising, going to be over 30% of the population. And one of the largest groups in the New Zealand population over the next 30 years will be Maori between 30 and 50. And how do we look at that? Well, if we look at the youth dependency ratios, you can see that during 1966, that basically we had about 0.7 of a person of working age for every Maori child. And we had twice that number for non-Maori. And Maori now have shifted that. So we're seeing that sort of worker to young dependent ratio shifting up quite fast, as it is with non-Maori. But when we get to the older population, it gets a lot more interesting. So this is the share of older people for every worker, worker for every older person. And you can see for Maori, it has been for 20 years with this very low older population. In fact, was just an absent population. But here we're seeing this conversion. And so the aging of the populations is going to affect non-Māori more than Māori. And just a final little analysis. What I did is I made a slightly barbaric computation based on some work that extrapolating beyond a reason for some work done by Treasury, where I gave a weight to the impact of older people, people are over 65, people under 65, and the positive effect on the workforce. And when you, rather than using a simple dependency ratio with adding both old dependents and young dependents, which I think is quite wrong, you can then see that for the non-Māori population, their capacity, if they were a single population to support themselves economically, is diminishing quite fast. For Māori, it's declining marginally, but not at all to the same extent. And that's because, of course, of the high birth rate and the growth, continued growth of people in working ages. I'll stop there, Peter.
Tēnā koe, Len, ngā mihi kia koe. Thank you very much, Len, for this very insightful and interesting and clear presentation. I love the use of your idioms, driving through the rear vision mirror, and a few other colourful ones as well. It was also quite sobering in some aspects, especially around the 1971 statistics and what's happened to Māori men over very different things over the years, and perhaps with all those mishaps that have happened, perhaps it's some of the answers to the reason why there's sometimes the trust isn't high between Māori men and government or even the health sector. And but at the end of the day, thank you very much for this very clear and enlightening presentation. Patrick, do we have any questions?
Sorry, sirens in the background. We do have one from Arindam, but I think it's already been answered. He asks, what happened in the decade around 1971 that could explain the trend in incarcerations around that year? I think we did end up covering that. Over to you, Len.
Well, we had the Mason-Garb report in the late 50s, which was based on teenagers mulling around milk bars in Lower Hutt. And that sort of created almost a fear, a panic that meant that young people were regarded as two things: part of the future generation and potential criminals. And so our rate of imprisonment or taking children into care was extraordinarily high. Also, Māori came into the urban areas. Like when the number of children were 50% in 1966, that generation that was 15 then was twice the size of the previous generation, but the number of Māori kids who were under 15 in the 66 in urban areas was 4 times 15 years before. So you had, I think you had this mainly Pākehā police force, school teaching force, the whole of the system was suddenly flooded by these cheeky little young Māori coming in. Or Peter will probably tell us more about that. But they were but just one interesting thing that's important: we took Māori children into the care of the state. The mean age was 13 and 14. We took non-Māori boys into the state at 16, and we've never really thought about the impact of bringing in so many much younger Māori boys into institutions of older non-Māori boys who had to have a worse threshold to cross. And I think there's a whole lot of dynamics that you get into when you start looking at the sort of demographic patterns. And we also don't even use our data very well. I've got a slide, if I had a second, Peter, I'll just show it to you, which is what happened. Here it is. This is a slide that shows you, this is from a study in 1957 when we followed every boy born in New Zealand till they were 24. You can see here the age of first court appearance. What it tells us on the right-hand side is of that generation born in 57, 46% ended up in a court, 24% or 22% of non-Māori boys. But if you look when the Māori boys came in to the system, they were very, very young.
Ngā mihi anō ki a koe, Len. Thank you once again, Len. I'm going to leave it as that. Again, very entertaining and very sobering in a way as well. If your questions haven't been answered, you're welcome to put them in the chat, and Len, if you've got time, you can answer them in the chat if you want to, but I'd like to keep on time because some people come in for specific presentations and 1 o'clock is almost here. So thank you once again, Len, and
thank you, Peter.
Tēnā koe Siddhartha, ngā mihi ki a koe, kua tā mai ki wānganui a tātou. Welcome, you've got Sid on your line. Welcome, Sid. Thank you for agreeing to present to us. I didn't know, I don't think I've met you before. I also work for the Ministry of Health. I'm in the Māori Health Insights team. Siddhartha is talking to us today about triangulating the Omicron outbreak. Thank you.
Thanks, Peter. Kia ora, everybody. Kia ora, namaste. My name is Siddhartha Mehta. I'm in the Intelligence, Surveillance and Knowledge team at the new Public Health Agency, which is situated at the Ministry of Health. I'm just going to be taking you through a little presentation on triangulating the Omicron outbreak. So let me just share my screen. And could I just check that that is now showing up? Excellent, great. So just a little bit about myself before I begin. My background is in public health. I did my postgraduate studies at the School of Population Health at the University of Auckland. And then after that, I spent time in doing, the first job straight out of uni actually was in clinical research, working with Professor Ed Gain on his hepatitis C drug trial. But after that, I joined regional public health, where I did public health advice and gave public health advice and did research on urban environments and housing, and was quite in the mix of the early days of the Healthy Homes program. For those of you who remember some of the interventions that gave evidence to the legislative change that we saw in healthy housing. Some of that work was done out of regional public health and the team of public health nurses there. So I was very grateful to be able to work with them there. After that, I spent quite a long stint, 3 years, also at Auckland Regional Public Health Service, where I did a lot of work with surveillance and intelligence experts like Ron King and Michael Hale. And the specific stuff that I worked on up there was on obesity and physical activity. So that was all in the public, that was all related to the Healthy Auckland Together program. After that, spent some time in the UK, where they brought me in to head a program on economic justice at this quite long-standing public health charity. Then I found myself at the ministry. So my approach to public health surveillance and intelligence is definitely driven by the focus on inequities. That's something that I feel like is one of the more important things that our surveillance systems need to measure and monitor in order for those inequities to be addressed. So I bring quite a lot of that type of approach to the work I do over here. And I'd also just like to, before I begin, just acknowledge that I'm just here presenting on behalf of my amazing team, who are just absolutely, I'll get into a bit of details about who they are, but just would like to acknowledge that all this work has quite a big team behind it, and also amazing support from the likes of the experts at ESR and the experts that are part of the COVID modeling Aotearoa group. But let's begin. So what's our team about? So what is the intelligence surveillance knowledge team about? I like to think of it as a public health think tank. So as a whole team, we provide expertise in technical and scientific advice and give evidence-based insights to inform action. Our team is comprised up of a couple of different groups. There's the Science Technical Advisory Group, and then there's the Intel and Data Analytics team, which team I'm part of. And people in our team come from all various backgrounds. So we've got all the way from really great data analysts to infectious disease epidemiologists to behavioral insight specialists to even a physicist and a journalist who also had a degree in atmospheric chemistry. So we're made up of quite a diverse bunch, and there's some good technical expertise, but then the team is led by some people who are really great at public health and public health surveillance as well. So we all really work together to gather and disseminate the latest scientific and clinical research. And for most of the time, our team has been focused on the COVID-19 outbreak. So that's given quite a good lens to the way we do our scans and our research work. Of course, we're the team who does the assessment of the epidemiological data to understand the trends and the effectiveness of various policy measures and public health interventions that we've put in place. We also work a lot with external technical experts like Sir Professor David Skegg and many others as well that you might have interacted with members of our team with before. Our bread and butter is really the last bullet point, which is we conduct routine reporting of COVID-19 and the related intelligence and surveillance. And this talk is really going to focus on that. And just before we move on to talking about that, the challenge with giving intelligence and advice based off surveillance data is that it often can be really incomplete. The data sources can themselves change, the definitions can change. So it's quite a challenging task to give accurate advice and especially give a focus on the long-term kind of trends and trajectory of things. And I quite like this little cartoon which makes fun of, the underlying patterns that we kind of see because we work in a really multidisciplinary environment. People's approaches to evidence and their knowledge about public health and data trends can all completely vary. So we have to work really hard in order to translate that evidence, to digest it, and to really kind of give a view of what's happening. So let me just dive into what's happened this year. So during the Omicron outbreak, the environment in terms of both the policy and the variant itself was completely different from Delta. Obviously, the variant itself that we had the outbreak of, Omicron, was more transmissible than Delta. And then also this year, we also had a lot of changes in our public health measures and strategy and how we approached it. One of the key changes that you see over here is the change from PCR testing to rats. Now that had a massive implication for the way that we did public health surveillance. We lost a lot of fine-grained resolution that we had with PCRs being paired up with contact tracing. So what that meant in the Delta time, what that meant was that we knew almost every single every single case and contact and probable contacts, and we had really good knowledge about who tested positive and who tested negative. During the Omicron outbreak this year, we just weren't able to do that. Lab capacity, we didn't have the lab capacity that could handle that level of testing required when the outbreak really picked up. So you can see that on the 24th of March, when rats were introduced, how quickly the weekly case rate climbed up to its peak in late February, early March. And because we lost a lot of that information, it was really hard work to address the information gaps. So we went from really granular level information about, place, person type of outbreak to much more population level information, what I would say. But an important point here is that the underlying dynamics of how the spread occurred didn't necessarily change. In the Delta outbreak, if people remember, while we were in level 4 lockdown, the outbreak was still really prevalent in people who were in transitional housing, people who struggled to isolate at home. So those factors have continued throughout this year as well, but it's just a bit of a difference that we lost the resolution of information that we might have had during the Delta time, and we came to more population level information. But the underlying dynamics of who was affected and where spread was most prominent, that did change, but the roots of it were still there. So I'll show you, and one more thing to add is the massive challenges in improving information and surveillance and analysis while you're in the midst of a very, very large outbreak. As it was a very challenging and tough time for our team to stand up new sets of information, stand up new sets of data, provide that analysis in a quick, responsive way for decision making to happen. So pre-Omicron, what did it look like? So before we moved to rats, let me just paint the picture. We were lucky enough to do things like case counts, and we stayed with case counts because, as I was telling you before, we had good understanding of like who tests positive, who tests negative. Rates are better, we've moved to rates, but in the early days, we could use counts to kind of monitor the impact. And the chart over there really shows you the very start of the Omicron outbreak. Because we had that fine-grained testing information, we were also able to cut our testing information by really important risk factors and determinants of disease. So this one is using housing deprivation, and this is combining testing with a housing deprivation score that is built from the IDI. And this is some excellent work that was done by the Health Geography Department and Daniel Exeter's team up at University of Auckland, the IMD 18 database. We were also able to follow testing rates. So here you can see testing rates are increasing, and then we're also able to follow test positivity, a really important early indicator in the outbreak. And here you can see in the early days that test positivity, as testing rates were increasing, test positivity was also increasing. So giving us very, very good signs that, you know, we had a serious increase of cases on our hands. And modeling has been a feature of our response for a very long time. So in the start of the year, we were able to obviously, and we still are able to track cases with the modeling scenarios that we have. And another way to like validate what was happening in the community. But then things changed, like I told you all. The kind of resolution of information changed. So we had to rethink of what we could do. And we had to take stock of the information that we had access to and kind of develop and explore new ones. So one of the first things that we did was looked at routine worker surveillance testing. So this was investigating it through surveillance codes in EpiServe. And we had two groups of workers who underwent routine worker surveillance testing. Those were healthcare workers and border workers. The legal order for border worker testing has ended, so we don't use them as a source anymore, but healthcare workers testing is still a really important piece of evidence that we use. And then we also explored the testing information, the surveillance information that came from hospital testing. So that inpatient test positivity was another bit of the triangle that we were able to start constructing. Wastewater quantification, this is again the amazing work done by ESR, and especially the people at Kanapuru Labs in Christchurch, Joanne Hewitt, Mike Bunce, and the team over there. Absolutely pivotal in giving us the information that we needed to kind of see what was happening in the community, because what was in the middle and what was the problem that we were trying to solve is that because we introduced rats, the mechanisms for introducing rats was through self-reporting. So we really had to find a way to triangulate those particular bits of information together. I can see I'm running out of time, so I'll go quickly. So what we were able to do this year in terms of approximating underlying infections was first use the routine surveillance data from border workers. So you can see here that the trends in border workers we were able to track across regions. And just as a cue, we were able to see what difference it had compared to the stuff that we were, the information that we're reporting from self-reported community cases. And just as a quick glance, you can see the scale difference. So the scales are completely different on the border worker versus compared to the case from the community, almost twice as high. So that gave us an understanding of what the under ascertainment was. Test positivity, as I was saying, was also a very, very critical trend to follow. So that was another piece of evidence that we were able to track increases from. As I said, wastewater quantification became another very powerful source to track overall infection trends. And then obviously in our suite of tools, we have forecasting, short-term forecasting, which we use the EpiNow package for. And this is the work that, and then finally, the more principled modeling that is done by COVID modeling Aotearoa, which kind of gives us what would be the overall trajectory of the outbreak and how we're tracking against it. To sum up very quickly, in order to kind of keep to time, I think one of the most important things that the work that we've done in this space is finding the data from the noise. So it's important to scan widely, have critical input from our own staff's experience and knowledge of working in public health, working in other areas of, you know, data management, information management. All those things are all critical things that come together when you're trying to make decisions under pressure. Once you have that data, the processing and exploitation of it can be is a massive time suck, and it's actually a very important task to do, but it can be very difficult. A lot of the work that we've done is to fix the data sets so they can be used for surveillance monitoring. And then because we've got this fire hose of information, really it needs to, when it comes down to, say, more to my end, it really comes to the so what type of questions, and that's where the analysis and production of the data is really important, keeping in mind with what questions we're being asked to give advice on, and that's the really pointy end of intelligence as well. And I think this goes back to the strength of the surveillance cycle, as you can see on the right hand side. It's that mix of integrating the data, analyzing it, thinking about the surveillance products that will come out, the dissemination and having action as the focus, but then continuously evaluating in order to understand what we need to kind of collect and move forward with. So some of the products that we produce for our decision makers, one of the key ones is the Trends and Insights report, which comes out weekly. And we also do a weekly live update. So that's another way we try and present the data. It's a 30-minute presentation every Friday that we give to all health sector staff, everybody involved in the response. This is a way to digest the report that we're putting out. And you can see on the right-hand side, it's a beastly report. We're coming up at 41 pages, but we try and cover quite extensively all the most important surveillance and pieces of information that decision makers need. So everything from infection trends to the demographic trends and cases, border surveillance, hospitalizations and mortality. We also cover international and scientific insights as well. All this information gets fed into various policy making and decision making processes like the COVID protection framework. And we also do the work on with our colleagues to assess the effectiveness of policy changes. Just bringing everything to a close, or summating, I guess, the direction of travel. One of the key things that we've learned is that we need to build a surveillance system that's fit for purpose and that gives visibility to underlying inequities. So as we've seen through the pandemic and evidence that's come out, that there's issues of unequal exposure, unequal transmission and susceptibility, unequal treatment, here it's really important to focus on social and economic determinants of infectious diseases, and inequities remain invisible through non-measurement. So doing our best to try and measure where the inequities could lie, looking at the ways that we could link our information to other sources. So a bit of work that we've done is linking testing information to the IDI so we can get more understanding of the social factors behind testing and the trends that we're seeing. And also having that inequity lens in mind gives a better baseline principle for what kind of systems we need to build in the future so we can mitigate the effects of inequity in infectious diseases and for other diseases as well. I'll wrap it up over there. Thank you very much to Barry and the team at PHONZ for pulling together this great online conference. Thank you so much.
Tēnā koe, Sid, ngā mihi ki a koe. Thank you very much for this presentation. It's very clear and enlightening. I found it to be a good summary of what's happened, and your explanation of the issues that came up and how they were dealt with is very good. We've actually come to the time now for our next speaker, so if anybody has any questions for Sid, perhaps if they don't mind putting them in the question and answers field, and if you have time, Sid, if you could look at those later on and write an answer if we have any, but it is 1:20 now, and we'll move on to the next speaker. Again, thank you very much, Sid. Right. I am now looking, yes, tēnā koe Arindam, no mai, haere mai ki Wainganui o tātou. Welcome Arindam to this PHONZ conference. We're looking forward to your presentation. Over to you.
Thank you. Kia ora, Peter. Arindam Basu. I am from the University of Canterbury, and in contrast to the presentations that we have had so far, which has been discussing mostly around the work that people have been doing, mine is more of a blue sky kind of open-ended thinking to say that what are we seeing and where we might be heading and what we may need to do. So this is the reason when I saw the advertisement for PHONZ conference coming up, I thought perhaps bring attention to these issues of OneHealth surveillance, because we have already been using surveillance, sentinel surveillance, genomic surveillance and others quite a lot, but are we connecting the dots? And this led to a rabbit hole of understanding several different things that I never thought that come to. So why don't I start sharing my screen and see what we have. So I'm going to share the screen. Is it all right if I share the screen? So can you see that the screen that shows OneHealth emerging zoonoses and organizing public health surveillance?
Can you make it on full screen, Karan?
Yes, I can do that. I certainly will make it full screen to see that it does show up. How about that now? Is it better? Okay. So this morning's data, for instance, for the COVID-19 pandemic, and you can see that the news is not very bright. And particularly, if you take a look at the green line, we said that New Zealand's case numbers, I mean, COVID-19 cases per million people is going through the roof. And this was certainly not the case a year ago and a couple of years back. Nothing to do with anything that we're doing at the moment, but that tells us that this thing is going to be with us for some time. It has been with us for some time. And the question then is how it all began, where is it heading? We don't know. And while we are at it, there's another enemy at the door. And this time you can see that the monkeypox cases are going up and up against. But that's only half the story. if you start thinking in terms of, what is going on in the world about many of these things, you will see that many of our information are quite dated. Take a look at this. And I have picked up all of these from the Our World in data sets, which I have found over the years, that it's been fairly up to date and accurate in terms of the data that they keep. So that's why I am reliant on that. But if you can direct me to some other ones that are better than them, I'm certainly eager to look at them. But you can see here is this, that the two very interesting trends. One is that global wildlife exports are going up. Yeah, and despite but then again, this is dated data till 2014. So I'm sensing that these numbers have gone up ever since. And at the same time, we see that there has been a decline in the monitored wildlife populations, as indicated by the Living Planet Index. So it tells you a complex story. And the story is this, that while there is continuing biodiversity loss, some people are gaining and some sectors are winning. And that's where you start seeing that there is an imbalance. And if we start looking into the history of previous monkeypox outbreaks, you see that a lot of them were because of the human-animal contacts, particularly among the pets that were carrying this. Of course, monkeypox itself is a misnomer, as you know, it's mainly a disease of small animals. And similar was the case with COVID as well when it started. So summarizing, we see that as COVID-19 rages, monkeypox is crossing 15,000 mark yesterday, jumped from 10,000 last week. Yesterday, we received the first case of a 7-month-old child with monkeypox from Spain. Marburg virus in Ghana has re-emerged. But at the same time, there are some things that used to be thought of as unrelated, or maybe perhaps connecting the dots, is this, that we are sensing record heat waves in Northern Hemisphere, wildlife in Europe. And just to bring a personal story, earlier this week, we had pretty bad strong wind and unusual heat battered us in Canterbury, Nor'westers. I hope we don't have it again anytime this season, but it's absolutely mind-blowing. I mean, I was driving through this and I just realized I was sweating inside the car, although this was winter. I know that as public health professionals, we have pretty much devoted a lot of time, energy, and lots of good work using our computations, using everything that we have in terms of building surveillance. But somewhere in our surveillance systems, we need to connect the dots. But as Tim Lash speaks about in Modern Epidemiology, Ken Rothman's classic, we need to build the why, what, and how of perhaps the next generation of surveillance systems. We need to have some kind of a plan for genetic surveillance, genomic surveillance. At the moment, we are doing very well with microbial genomic surveillance. So we do this in order to keep the genetic changes of microbes under surveillance, and tight surveillance, so that we can identify patterns of epidemics when they emerge and preempt them. But what I'm going to argue is this, that we should increase the ambit of our surveillance systems much wider. So we probably need a case for human genomic variation and SNPs to bring under that radar. But then you would be arguing that if you were to build polygenic risk score systems and try to model, ensuring epidemics and future epidemics, the argument here is this, that the genomic variants are probably not going to explain a lot of the variations that we're expecting. So we need to build in a little bit more in terms of taking in family data and the wider circumstances of whānau and everyone else. And because we are connected to each other, we need to expand the surveillance to almost practically everything that we're working with. So the vets are important, the food that we consume are important, and so on and so forth. We just build a wider scale, reminding of the WHO, FAO, ILO's tripartite alliance documentation, which talks about expanding the scope of everything that we are doing to preempt and understand ongoing and future pandemics. So this is where I'd like to propose the OneHealth surveillance system, where, according to the WHO definition, at least 2 sectors of human health, animal health, plant health, food safety, wildlife, at any stage of the surveillance process. But how are we doing that? I don't know. I'm not sure that I have the answers to this, and I'm on the quest. So there were things like a lot of intersectoral coordination, capacity building are needed, not only from the science part of it, the environment, human, animals, but also the society. So, you know, Sid's earlier comment that we need to understand the social and economic and determinants of health, and the addressing the inequity and inequality. That's really the way, if we really want to do something about it. Are there models, you know, going by that? And there are a couple of things that I kept up. This is a good paper from Keenan and Rushton, where they were looking at antimicrobial resist surveillance. And you can see that there is a tight integration between the vertical and horizontal patterns of building surveillance system quite tightly to see how we can track antimicrobial resistance. But we can probably scale this up for everything that we are going to do here. So I'd really like to, you know, leave it short, and I'm more interested to hear your views and take your questions and your concerns and your comments. I don't know I've got answers to everything that I can think of, but please, if we could build something together and more holistically, including the universities, public health agencies, sectors, industry, I think there is a scope that we could probably look future pandemics in the eye and stop them before they happen. It will be a very boring future, but that's the boredom we need. So, and I put together a GitHub repo if any of you are interested. So I'll leave there and wait for your questions and comments.
Tēnā koe Arindam, ngā mihi ki a koe. Thank you very much, Arindam, for this entertaining and different look at what's happening at the moment. I'm always very happy to see a different view and a different look at things. I hadn't seen the global wildlife export graph or the living planet index graph, or and again weather anomalies, and I really like the idea of expanding the surveillance angle. I don't know what word you use, but expanding the surveillance. That's really good, and I'd like to see more of that. We will open it up for questions now.
We've got a question from... Go ahead, Rob.
Aaron, it's Barry speaking. Thank you for your presentation. Can you hear me?
Yes, I can hear you.
One of the things that's always interested and somewhat surprised me about the One Health concept is how it's been primarily driven by the animal epidemiologists,
yes,
rather than the public, well, us, the human ones. We've traditionally tagged along behind, and in fact, when you, as you well know, that epidemiologists are actually trained, core training is exactly the same, but as human as animals. And what solution, any solutions you've got to that is how can we beef up the human epidemiologists to get more involved in it?
You and I are on the same boat. I mean, we've been sensing this, you know, ever since the concept of One Health has come. It's been driven by the vets and the and you know, till about recently, when we used to talk about epidemiology, we would not consider veterinary epidemiology as part of it. And of course, I don't know, but probably we should as epidemiologists, we might want to expand the scope of the work that we do on a daily, every day, to include those concepts. But frankly speaking, you know, I'm waffling. I don't have the correct answer to that, but I'm totally with you, and I see your point. I understand it. No answers, to be honest.
Another question here from Mike.
Okay. my first question was, I think in the light of your discussion, the future National Public Health Service has got to get into doing genomic surveillance. It's going to become our bread and butter, and it has to be ripped out of the hands of ESR. Secondly, I don't know if people, I think Arindam is starting to think big enough, and you know, we have to be surveilling all the RNA and all the DNA all the time, and you know, obviously there'd be all sorts of caveats with that. Working with human genomics is that's a whole different can of worms, but all the microbes, all the viruses, we should be, you know, planning for a future where we're sequencing them all the time. And so you can think of our public health protection officers, say boarding a plane as it lands, getting a little canister, having a little sensor and sampling all the air for all the exhaled viruses on the planes. Routine wastewater surveillance. What does that mean? What are normal viruses that are, you know, inconsequential for health versus the ones that are significant for health in wastewater? And so there kind of has to be a thinking of a national scale of a genomic surveillance for both MPI, even border control, maybe not, don't know, but certainly for animal health and human health within our across the whole of government. So I've come out of a pretty big animal bioinformatics program. My impression was that the technology is only just starting to emerge where you can track things that are not simple SNPs. So I asked a question about recombinant variants in the microbes. Yes. Are we able to track those? So I think that the systems can be built, but it's a very aggressive kind of bioinformatics-led project, and there's normally we avoid projects like that because you know, no one you know wants to get into the bioinformatics, and it's quite kind of difficult, and probably those problems will be solved elsewhere in the world, and we'll just follow along behind them if we're not careful. Yeah, anyway, sorry, that's me. You've hit a few buttons there, and I'm right keen to try and see what it is and to make it happen.
Yeah, no, I think that's some absolutely extremely valuable points there, Mike. But my sense is this, that we are doing rather well in microbial genomics. Aotearoa has started putting together some kind of human genomics evaluations. I know that some longitudinal studies have started genome sequencing, but by and large, we are not doing very well in terms of genome sequencing our populations. Human genome sequencing, we are still lagging a little behind. The last month, I was trying to put together a PRS for understanding the polygenic risk score calculations, understanding how we might model them. I know that collectively, the PRS may not explain a whole lot of variations in, say, for example, you know, streptococcal, you know, or sort of, you know, myocardial diseases that we see in children who are infected with streptococcal sore throat and skin infections. But when you start putting together a wider picture of even the family studies and then taken together, they can be quite valuable and helpful. So even if we were not to do microbial or human genome sequencing built into the surveillance, we could certainly take the wider family stories and family structure, the whanau as it is, and bring them under the surveillance to understand better what will be possible genetic contributions, not necessarily driven by the bioinformaticians, but we could just build those things into the picture. What that too is not working as well as we should. Whereas if you look at countries such as States or the UK Biobank, we really need some kind of a biobank-like activities in New Zealand to get it forward. So that was just my thought as it is. But absolutely great thinking there, Mike. I mean, I cannot appreciate more.
Yeah, so the like the price. Sorry, I'll go back and like the price of you probably want 100,000 people, $1,000 a person. That's $100 million project. Yeah. And that's a big health budget to do it properly. And so then the next question you've got to ask is, where can we spend $100 million in the health system for the best bang for buck? And I don't know the answer to that, but the biobank is probably a 100 million investment. So that's huge. Yeah, and a lot of it's to do with the immune genes, and people, they will ignore the fact that the immune genes are actually the hardest to assay with a whole genome kind of a sequence with a short read, cost-effective kind of a thing. So you're trying to get long reads, and there's all sorts of stuff that kind of makes it hard. But $100 million, where would you spend that for health? And if it's a genetic answer, yoo-hoo, yeah, let's do it. But so I think that is that's a really big conversation, and it's up to our treaty partners in presumably the Māori Health Authority. If you ask them where would they like to spend $100 million, they will kind of tell you, and probably the answer might be houses. You know, I don't know. That's a really tough question. But the viruses and genomes, you know, we might have a chance with those.
Thank you, Mike. It's time for our next speaker, and thank you once again, Arindam. If you have any comments to make to Mike about his, I'm not sure if it was a question or comment, you can put those in the questions and answers if you don't mind. But ngā mihi anō ki a koe, Arindam. Thank you very much for coming to us today.
Yeah, thank you.
Hello everyone, I'm Karl Majorhazi. I work at StatsNZ, and I apologise for not doing this live, but we have some stability issues with our technology, and it's much safer this way. I'm a spatial professional working in a statistical organisation, which means that I see things a little differently from most folks. One of those things is the notion of geography. If you look at the quote from Waldo Tobler, it's the first law of geography. And it states that everything is related, but near things are more related than distant things. So just keep that in mind as we go through this presentation. I thought I'd share this with you because it seems to be pretty relevant today. The data we have for the present crisis was collected to relate to the previous one. I also like number 6. If you've got the right data, you have the wrong problem, and vice versa. So it's in this context I want to talk to you about population grids. We think of population statistics as being about people, but they're also about places, and people are one characteristic of a place. Linking people to places helps us determine things like access to services, proximity to hazards, but the important thing to remember is that location is a primary key, meaning that any other data with a location component is automatically and implicitly related. Population grids are not a new thing. The European Union have mandated population grids for all of their member states. The Australians have also produced a population grid. We see gridded data in all sorts of places that we're familiar with: satellite images, weather maps, even population grids. But we see a future for an official standard New Zealand population grid, and that's where we want to go today. We start by setting up the grid framework. A square grid, which seems to be the most basic type of grid we can produce, at 1 kilometre, 500 metres and 250 metre resolutions to cover a whole multitude of applications. It goes out to the 12-mile limit and includes the Chathams, even though it's an NZTM projection. Now, population data relies on a framework that was developed back in the 70s, a nested hierarchy of geographic areas of increasing population size. When you see smaller areas, it means population density is higher. And that's been the backbone of statistics for a long, long time. So let's step back to first principles and have a look at how the geographic components of statistical geographies works. So we start off with a piece of land. That land is then surveyed and turned into a bunch of land parcels. Councils come along and allocate a street address to those land parcels, and those street addresses then get a series of coordinates, which are those green dots. Then there's structures built on them. And some of those structures are dwellings, those yellow dots. And those yellow dots are the things that we want to collect population data on. It's a census of population and dwellings. We group together 30 to 60 dwellings into mesh blocks, originally developed for census enumerators so that they can walk around an area to knock on doors, give out forms and get them back. But we also use them as a way of aggregating data from all of those dwellings. We group these mesh blocks, or SA1s, together into larger units with 1 to 4,000 people, they're SA2s, and they allow us to release more complex data for an area. And this is what we're proposing to add to the mix, a grid. In this case, it's 250 metres, and as you can see, it's agnostic of any of the physical features. So I'd describe it more as an analytical geography rather than a statistical one. But one size grid does not fit all purposes. If we zoom out, the yellow is a grid of 500 metre squares. And the red grid here is 1 kilometre apart, which is the European standard. Let's add some data and see what happens. So this is what you would see if you went straight from a table to a map. The population ranges between the colours is narrow because in theory each of the areas has the same or very similar population, which is why it's very hard to distinguish any spatial patterns from this data. The first thing we have to do as cartographers is to normalise the population so that each statistical area can be compared to one another. This leaves us with another conundrum. There's not a single piece of land in this picture that shows as uninhabited, yet we know there are large areas of forests and farms where there are no dwellings. There are also statistical areas that have multiple communities in them, and communities that are split into different statistical areas. It's necessary to do this though, because geographic aggregation is our first line of defence and disclosure control. The downside is that some of our more isolated and vulnerable populations are hidden from us, and this provides particular challenges for analysis. But modern technology allows us to add more spatial precision to the same statistical data without compromising privacy. We can simply move the aggregated statistical data back to where people actually live. It's what we call disaggregation, and here's how it works. We start with statistical area populations and the locations and dwellings. We then apportion the population back to those locations and then aggregate the populations at those locations to the new geographic areas, in this case the grid. Ideally we want to bypass that first step and aggregate the raw populations to the new geographies. But there's a catch. Our current methods of confidentiality, that is suppressing data with low counts and perturbing the rest, won't work for grids because there are a lot of grid cells that have low population counts. So we're working on new methods of confidentiality that will allow us to build grids directly from the raw data. And back to the maps. Somewhere inside that red box is the community of Ruatahuna. The yellow dots are the address points / dwellings. The orange lines are the boundaries of statistical areas. Now the thing to note is how many of those red dots are sitting right on the border of two statistical areas. And some of those dots in Ruatahuna are combined with some of the yellow dots on the left-hand side, which are on the outskirts of Minganui. So if we zoom in, we can see that the community is split because the statistical area goes down the road and there are people living on either side of the road. The grid ignores all of that and just shows you the raw patterns of habitation and population density. This is a comparison of the two sizes of statistical areas and two resolutions of grids. Note that the grids tend to keep the same spatial pattern of population distribution, whereas that's more closely represented in the statistical areas by the way the areas are drawn and not the population data within them. And this is an example of the modifiable area unit problem, which is a particular devil in our data. So let's summarize where we've got to with grids. They're a fixed geography. They don't need to be maintained the same way we have to maintain statistical areas. And because they're fixed in place, they're great for time series. They're already normalized by land area, so it's analysis ready. They're great for spatial analysis and visualization applications. The spatial patterns in data are preserved throughout multiple resolutions. We can show where people don't live. And because we're linking people with place, we can link other data to people as well. And it minimizes the devil in our data, the modifiable area unit problem. Let me finish up by giving you another view of our data, and this time it's in 3 dimensions. What you're looking at here are statistical areas where population has been used to give the area height and colour. The bluer areas have higher counts, therefore they are higher. But what you note here is that it's still relatively flat. That's because all of the areas are designed to have pretty much the same population size. And this is the same view with a population grid. Thank you for your time. If you're interested in this work or have some comments for me, I would love to hear from you. Thank you.
Ngā mihi kia koe, Karl. I thoroughly enjoyed that. I thought there were great graphs in it, and I thought the mapping was really good and really fresh, and I loved the way how you built them up. I thought that was great. I'm not a mapper myself, but I really enjoyed that. Thank you. Do we have any questions for Karl? Maybe this is the first question. What mapping software package did you use to do that?
We use Esri tools. ArcGIS Pro mainly, and ArcGIS Online for our 3-dimensional maps.
And you said you'd be happy to hear from anybody. Can we have your email address? Can you tell us what that is? Or
I'll type it into the chat.
Oh, very good.
There is a hand up, Ellen.
Hi, Karl. We were just talking about this recently, actually, mapping kind of the different statistical areas, and particularly the time component, looking over time. So this would solve a lot of the the queries that we had and all of the complexity that's there at the moment. Do you have kind of a time frame as to when this new way of splitting out the population will be kind of available to be used widely?
Hopefully very shortly, because we're just getting endorsement from various internal expert and governance groups before we can release something for you to have a play with. So the first step is to put something out there, and you can tell us whether it works for you or not, and whether we need to make some changes to the specifications before we write them into the statistical standard.
That's great. And just the other point that you made around the personal identifiable data. So will that obviously be a consideration when you're releasing those new areas?
Well, the grid minimises it. It doesn't eliminate it altogether, but that's really a factor of geography. And when we put an area together, it means that people are not spread homogeneously and evenly around the geographic area. So when we see large tracts of lands and rural areas, we know people are not living all over the place. There are not people living on the top of Mount Cook. But if we go to smaller and smaller areas, that's less of a problem.
Awesome, thank you.
There's one more question in the Q&A for you from Mike.
Yeah, okay. Yes, we've thought about hexagonal grids, and I'm a fan because they're a much more computational friendly geography, and hexagons are closer to nature's shapes. But the reason for going for square grids is that it's something that people understand and are familiar with. So it's a good one to start this program of work off with.
Oh, and one more question from Vladimir.
Well, the Statistics Act is being reviewed, and it, from what I understand, it does not absolve us from confidentiality, maintaining privacy. So it really doesn't affect this work at all.
Kia ora anō, Karl, ngā mihi ki a koe. Thank you once again for presenting. I'm going to just do a quick summarise now, and then we'll have a closing karakia. I'm not going to speak about summarise every presentation that we've had today, other than to say all of them were very interesting, very clear, and very informative. And I'm so pleased to have this opportunity. And PHONZ is so pleased to have this opportunity to host our presenters and to present our listeners with something to look at and learn from this afternoon. So, ngā mihi kia koutou katoa, ngā tai o te mihi kia koutou. Greetings to all our presenters and all our listeners today. And on behalf of PHONZ, thank you very much to all of you. And Tim, can I leave the closing karakia with you?
Yep, kia ora Peter and mahi, Peter and Patrick for chairing today. It's been smooth sailing. Me karakia tātou, nā mai ia nā hua, o te wao, o te nā kina, o te wao tai, o te wai Māori, nā tāne, nā ronga, nā tongaroa, nā maru, ko ranginui I tu ihi noi, ki papa tukanuki, I toko ti nai, turu whakamoa, kia tina, tina, huie, tae kia. Ka pai. Thank you, everybody.